Yes. Yeah. What sort of onion you open this one? Start.
All right, a very good morning, everyone. Welcome to day 2 of Deep Dive Head and Neck Cancer. We had wonderful sessions yesterday on oral cavity and maxilla, and we had a live robotic surgery as well. So in the same speed, let's kick off today's session with Dr. Cecil Kainikal from RCC Trivandrum. I invite you to start your part 2 of your lecture on imaging in CA larynx.
Good morning. So today I'll be discussing about the treatment decisions in carcinoma lies based on imaging, a clinician's perspective. The larynx, which lies between the vertebra C3 to C6, and it extends from the tip of the epiglottis. This is the tip of the epiglottis to the caudal edge of the cricoid cartilage. So it is between C3 to C6 vertebra, and this epiglottis has a suprahyoid part which is free part, and it is fixed part which is fixed to the thyroid cartilage by the thyroepiglottic ligament. So this area, this is the supraglottic larynx. Supraglottic larynx extends from the tip of the epiglottis to the cricoarytenoid joint. This is the cricoid cartilage. On top of that, it is the arytenoid cartilage, and this is the cricoarytenoid joint, which is the functional unit of the larynx. So this extends from here to the level of the cricoarytenoid joint. That's the supraglottis. Supraglottis contains 5 structures. One is the epiglottis. So this is the you have the epiglottis here. Epiglottis have an infrahyoid and a suprahyoid part. Then you have the arytenoid cartilage. You have the aryepiglottic fold. Then you have the fold scot, that is the inferior most mucosal reflection of the aryepiglottic fold. Then you have the ventricle. So these are the 5 structures. And there is 2 spaces, the pre-epiglottic space and paraglottic space, that I will discuss later. So that is supraglottic larynx. Then you have the glottis, is a tiny area. Below that is the subglottis. And the larynx is different from other head and neck sites due to various factors. One, if you go by the size criteria, if you go by this for the staging in oral cavity, oropharynx and hypopharynx, up to T3, it is the size criteria. In larynx, it is not size criteria. It is extension into the subsites. And it is the only tumor in head and neck where you have a subclassification for T1 tumor. It's T1A, T1B. The prognosis among the subsites is also different. A glottis present early, the chance of lymph node involvement is low, good prognosis. Supraglottis have a high chance for lymph node involvement. Subglottis is very rare. And if you look into the subsite, there is, if you into the guidelines in NCCN, have a separate guideline for supraglottis and glottis tumor. There is no separate guideline for oropharynx and tonsil for oropharynx, but there is a separate guideline for that. So this is how it is different. And then the imaging, coming to the imaging, all patients with larynx biopsy proven need an imaging, and the CT scan is the investigation of choice. The CT scan is because mainly we are dealing with the bone, the cartilages, so the specificity is better with CT. MR is having high sensitivity, but specificity is low. In look to prevertebral fascia involvement, MR may be superior. In all other situations, CT is good enough in the staging of CA larynx. And the role of imaging, it is one for staging, mucosal spread and locoregional extent, treatment decision making, where to go for radiotherapy, surgery, or where to go for the staging and the treatment decisions. And most important, one other important thing is to have a radiotherapy planning, evaluation of the disease, and for follow-up. So I will take supraglottis first. It contains 5 these structures. One epiglottis, the array-epiglottic fold, arytenoid cartilage, false chord, and the ventricle. And this I have already discussed. The epiglottis start appearing at the level of the floor of the mouth. So if you look into the cadaveric section, you can see this is the hyoid bone. You have the hyoid bone, okay, and then you have this is the pharyngoepiglottic fold here. This is the epiglottis. This is the epiglottis. Then the pharyngoepiglottic fold is the inferior-most portion of the oropharynx. The inferior boundary of the oropharynx is the pharyngoepiglottic fold radiologically. And on either side of this, you have the vallicula here. This is the median glossoepiglottic fold. And on either side, you have the vallicula. Vallicula is part of the oropharynx. It's not part of the larynx. Okay. Then this is the epiglottis you have seen. Then radiologically, you can see this is the epiglottis here. This is the median glossoepiglottic fold. On either side, you have the vallicula here. And the pharynx, this is the pharyngoepiglottic fold. Pharyngoepiglottic fold is also called the, this is the lateral glossoepiglottic fold. The CT scan, if you look in this, you can see that the tip of the epiglottis is seen at a higher level. So that is the free portion of the epiglottis. Okay. Then you have this is the, you can see in the sagittal view, this is the epiglottis here. This is a vallicula. This is the base of tongue. This is a vallicula. And this is the lingual surface of the epiglottis. And this is the laryngeal surface of the epiglottis. And this is a hyoid bone. And there is a ligament which is connecting the epiglottis and the hyoid bone, which forms the roof of the pre-epiglottic space. This is a pre-epiglottic space. And this ligament is called the hyoepiglottic ligament. So if you know all this, it is very easy. Then this is a pre-epiglottic space. Okay, this is a free edge of the epiglottis in the coronal view, and this is the you can see this is the pyriform fossa. This is a pyriform fossa. The aryepiglottic fold here. You can see the paraglottic fat here. This is the paraglottic fat, which is very clear. And early involvement of the paraglottic fat involvement is better seen in a coronal view. So this is a coronal view. You can see that is a paraglottic fat. The aryepiglottic fold extends from the lateral surface of the epiglottis. So this is the epiglottis. Okay, this is the epiglottis, and this is the pre-epiglottic space. This is a pre-epiglottic space. This is at the level of the hyoid bone, and you can see the laterally, from the lateral on either side, there is a fold which extends from the epiglottis to the arytenoid cartilage. That is the aryepiglottic fold. And lateral to the aryepiglottic, you have the pyriform fossa. This is the right pyriform fossa. This is the left pyriform fossa. The boundaries of the pyriform fossa is formed by by the aryepiglottic fold, and laterally by the medial surface of the thyroid cartilage. So this is the lateral, this is the medial edge of the thyroid cartilage, and this is the pyriform fossa is not part of the larynx, it is part of the hypopharynx. And you have the posterior pharyngeal wall. This is the posterior pharyngeal wall is also not part of the larynx, it is part of the hypopharynx. So you have the structures, the epiglottis here, the aryepiglottic fold, then you have the pre-epiglottic space here. I will discuss the pre-epiglottic space later. So if you have a tumor in the aryepiglottic for epiglottis, you can spread anterior to the pre-epiglottic space, then it becomes T3 disease. And this area is rich in lymphatics. That's why there is a high chance for lymph node involvement. Then from there, laterally, it can extend into the aryepiglottic fold here, the aryepiglottic fold. Then if you have a tumor in the aryepiglottic fold, it can spread laterally to pyriform fossa, anteriorly into the epiglottis, and laterally into the paraglottic fat. So this is the aryepiglottic fold here, and this is the thyroid cartilage, the level of the thyroid cartilage. Epiglottis here, the aryepiglottic fold here. This is a pyriform fossa. It's a posterior pharyngeal wall. Now what you look for in imaging, one is you always compare with the right side with the left side. That's a very easy way of looking and learning radiology. And you look for the asymmetric soft tissue or thickening, the abnormal contrast enhancement. You definitely see any frank lesions and obliteration of the fat planes, like the paraglottic fat is obliterated, the pre-epiglottic space is involved or not. So that's how you look for. So here you can see you draw a midline. Okay, you see the first normal structures here. This is the epiglottis on the left side. You can see the aryepiglottic fold here. This is on the aryepiglottic fold. Posterior to that, that's the pyriform fossa here, right side. But on the left side, you can see an enhancement lesion that is arising from, this is the epiglottis here, epiglottic fold, and epiglottic fold, obliteration of the right pyriform fossa. Here you can see very well make out the left pyriform fossa here, but you cannot make out the pyriform fossa here. So this is a T2 disease because two subsides are involved. And if it is involves the paraglottic fat a little down, then it becomes T3. Again, this is another lesion which is extending from the epiglottis to the epiglottic fold here with obliteration of the right pyriform fossa, again a T2 disease. Now, why you need to know the T1 and T2 supraglottic larynx? The T1 and T2 supraglottic larynx, there is a high chance for lymph node involvement. In fact, T1 or a T2, in T2 disease, you can have 29 to 42% chance of lymph node involvement, subclinical lymph node involvement. So, a supraglottic larynx, T1 and T2, you need to treat the lymph nodes. That's very important. That's why you need to know. And even if you do surgery, a supraglottic partial laryngectomy, you have to do a bilateral neck dissection. 1/3 of the patients will require an adjuvant radiotherapy because of the lymph node positivity. So in this patient, this is a situation where you have a lesion in the epiglottis extending into the epiglottic fold. You have to treat a prophylactic dose of lymph node to 2, 3, 4 lymph nodes to a dose of 54 gray if you're giving radiotherapy to these patients. That's the importance of knowing the lymph node involvement. The other thing is the arytenoid cartilage. The arytenoid cartilage lies on the cricoid cartilage. Okay, this is the cricoid cartilage. Cricoid cartilage is more broad posteriorly and it lies on the superior. You have the arytenoid cartilage. Arytenoid cartilage it's a pyramidal shaped cartilage. It have an apex and a base, and the apex rests on the superior surface of the cricoid cartilage, and it forms the cricoarytenoid joint. And this is a functional unit of the larynx, and we need to know whether it is involved or not. So that's the arytenoid cartilage. And how you look for the so that is the arytenoid cartilage. I will show you how to look for that in CT scan. And before that, I will discuss the fold score, and that's at the level of the UC arytenoid cartilage. So fold score is nothing but the inferior mucosal reflection, the epiglottic fold. There are different names for that: the vestibular ligament, fold score, vestibular fold, and it is anteriorly connected. This is in front. It is the angle of the thyroid cartilage. This is the epiglottis getting attached to the thyroid cartilage by the thyroepiglottic ligament. Just below that, at the level of the angle of the thyroid cartilage, this anteriorly and posteriorly it is attached to the anterolateral surface of the arytenoid cartilage. So this is the fold score. How you look for fold score? You just trace the level of the arytenoid cartilage. So if you're seeing arytenoid cartilage, you are at the level of the fold score because the fold score is attached to the arytenoid cartilage. So you have a lesion in this is the epiglottic. You have a lesion in the fold score. It can spread laterally to the paraglottic fat here, and just lateral then in the inner cortex of the thyroid cartilage, then extralaryngeally, and anteriorly can gain into the pre-epiglottic space. And posteriorly it can gain access, and you can cause the thyroarytenoid gap can be widened, and it can gain access posteriorly. And this is the arytenoid cartilage. This is at the level of the fold score. You can see a thin hypodense area here. This is a thin hypodense area. That's a paraglottic fat. All these spaces appears black in CT. Yesterday I told you when I discussed the oral cavity, we have seen the MRI scan. It was hyper intense in MR. In CT it is hypodense. So this is the area of the paraglottic fat. So if you have a tumor there, laterally it can extend the paraglottic fat, then into the inner aspect of the thyroid cartilage, thyroid destruction and extralaryngeal spread. And it can gain access to the pre-epiglottic space. Posteriorly it can gain access. The thyroarytenoid gap can be widened. So this is a T3 disease because you see the left side. You can see the left side. You can see the paraglottic fat here. Right side, you can see an enhancing lesion there on the right side, and the paraglottic fat is widened. And you see this is the thyroarytenoid gap here, and it is slightly widened on the right side compared to the left side. Can you make out that? So this is gaining access posteriorly. We have not seen any enhancement posteriorly, but the thyroarytenoid gap is widened. It's a T3 disease, and this patient should undergo chemoradiation. And so that's if there is no aspiration. Okay, the paraglottic fat here this is all at the level of the supraglottic larynx. You can see that this is the right paraglottic fat here. In the left side, the right side it is obliterated. You can see an enhancing lesion there, and here it is almost coming to the pre-epiglottic space here. Same is here on this CT scan as well. And you can see the left area epiglottic fold and extension into the paraglottic fat. Again, it is a T3 disease. Then I have to discuss two spaces. One is the pre-epiglottic space, and other I have already discussed the paraglottic space. The pre-epiglottic space is bounded superiorly by the thyroepiglottic ligament. You cannot make out the ligament in a CT scan, but we presume this is somewhere here between the hyoid and the epiglottis, the hyoepiglottic ligament. And anteriorly it is the thyrohyoid membrane, because that's the area where there is no bone, there is no cartilage there. That's a free space the tumor can have extension into this thyrohyoid membrane, and again it can have an extralaryngeal spread. I will show you that. And the bounded posteriorly by the epiglottis. Here it is epiglottis here. So that is the pre-epiglottic space. And this is a pre-epiglottic space. This I have shown you earlier also. That is, this is a coronal view. I will show you in the axial plane. So this is the this pre-epiglottic space. Okay. And here you can see a lesion involving the epiglottis extending into the area epiglottic fold. So it's a T3 disease. The standard treatment is to go for a chemoradiation program. Now coming to the ventricle, it is very difficult to make out the ventricle in the axial plane. Okay, it may be we have to use a coronal view to see the ventricle. Okay, so the ventricle is between the false cord and the true vocal cord. Okay, so this is the false cord and it is between the true vocal cord. You have a ventricle there. So this is a coronal view. Can you make out this area? So this is the false cord and this is a true vocal cord. Between these two is a small slit-like structure. That is a ventricle. So these are the structures which now I understand that you can make out the structures in the supraglottis and also to some greater extent the T1, T2 and T3 disease. And at the level of the true vocal cord, the structures which are seen, one is the vocal ligament here, the muscles, the thyroarytenoid, the medial and lateral belly, and sometimes this is the vocalis muscle here. And you can see all the bosses are seen in that same plane. If you're seeing the thyroid cartilage, cricoid cartilage and arytenoid cartilage in one plane, that's the level of the true vocal cord. Very easy to understand. You see all the cartilages are in the same plane. It's easy to say that that's. And another important structure which we have to bear in mind is the apex of the pyriform sinus is also at the level of the true vocal cord. So the apex of the pyriform sinus, this is also at the level of the true vocal cord. Now, how you look out in CT scan, you have the thyroid cartilage here, you have the arytenoid cartilage here, you have the cricoid cartilage. Yes, you are at the level of the true vocal cord. It's easy to understand. And you have seen a very small hypodense area lateral to this area. Can you make out that? This is the apex of the pyriform sinus. So you have it has a base which is towards the up, and it's an apex. The pyriform sinus, that is the apex of pyriform sinus, because it's not matter of discussion today. There is a high chance for a central lymph node. 6A and 6B lymph nodes are likely to be involved. There is a lesion involving into the apex of the pyriform sinus. That's the importance of that. Then this is again similar picture. Now what is anterior commissure and posterior commissure radiologically? Anterior commissure is very easy. The meeting point of the two cochlear cords, that is the anterior commissure. It's very simple. Second, what is posterior commissure? Posterior commissure is the area between the two arytenoid cartilage. You have the cricoid cartilage, arytenoid cartilage, and this is the interarytenoid area. Very easy. That is the posterior commissure. Yes, clear? Then now we have a tumor in the vocal cord. How the tumor spread? Okay, you are seeing in the endoscopy or in the when you do you can see in office endoscopy. Is if you have a tumor there, then it can spread laterally. Okay, really there is no paraglottic fat at the level of the true vocal cord. Then you can spread laterally. It can go the erosion of the inner aspect of thyroid cartilage, then it becomes T3. Okay, if it's through and through cartilage, it becomes T4A, and it can also gain access to the anterior commissure here, the posterior commissure here, and you can have it is again divided into the anterior 1/3, middle third, and posterior third for the discussion sake, and also for the thyroarytenoid gap can be widened, and it can gain into access to the posterior, the postcricoid area. So how you will look for in the axial and in the various planes, I will show you. You have a lesion there. This is the arytenoid cartilage. This is a cricoid cartilage, thyroid cartilage. You are at the level of the true vocal cord. You are seeing the the apex of the pyriform sinus. You can see an enhancing lesion in the left vocal cord extending from the anterior commissure to posterior commissure. You can see a posterior commissure is also involved. Entire left vocal cord is involved by the tumor. And if the mobility is normal, no subglottic or supraglottic extension, then it becomes a T1 disease. This is how you look in the sagittal view. So this is the arytenoid cartilage, this is the cricoid cartilage, and this is the thyroid cartilage. If you are seeing all this, then it becomes at the level of the true vocal cord. Now you can see that you have a lesion in the left vocal cord. You can see an enhancing lesion, then left vocal cord. It is crossing the midline, so anterior commissure is involved. It is opposite side. It is T1B if the mobility is normal. But here you can see the lesion is extending down into subglottic extension, because usually you should not see any soft tissue in the cricoid cartilage. So if you see any soft tissue in the cricoid cartilage, you have to think that you are dealing with a lesion extending into subglottis. That's a minimal subglottic extension. So this becomes a T2 disease. So generally this patient is not a candidate for laser because the lesion is crossing the midline, anterior commissure is involved, and the patient is having a subglottic extension. So purely a mid-cord lesion, no anterior 2/3, anterior 1/3, posterior 1/3, all the commissures are free, and there is no subglottic or supraglottic extension, and the mobility is normal. Then radiation and the laser becomes equivalent in terms of local control. Now coming to T3 disease, okay, I have only 2 minutes. Give me 2 minutes extra, please. Okay, yes, thank you. So then, so this is an inner cortex involvement. You have an inner cortex involvement, okay. You have seen all this, you can see in inner cortex involvement. Okay, this is inner cortex involvement. You can see a subglottic extension also. If you have a lesion in the cricoid cartilage, it's extending down, it becomes a subglottic. So it's a T3. You should have a thin slice CT scan in this cut, in this patient. Otherwise, sometimes an extralaryngeal spread is maybe missed. So this patient is a candidate for chemoradiation. But if there is a through and through, then this patient becomes a candidate for a total laryngectomy. So that you need a thin slice CT scan in this cut. So what is T3? T3, we have said T1, it is a fully mobile cord in a vocal cord, fully mobile cord. It is confined to one vocal cord is T1A. If it involves two, then it becomes T1B, no supraglottic or subglottic. If there is an impaired mobility or extension into subglottis or supraglottis, then it becomes T2. In T3, is these five things can make a larynx T3. And 2 are clinical, that is, and 3 are only radiological. This is given in different color. Hemilarynx fixity we can make by an endoscopy, and post-cricoid involvement can also be made out. But the paraglottic fat involvement, the pre-epiglottic space, inner cortex, this can only be made out by radiology. That's the importance of radiology. Another important factor which we need to look into is the airway. Okay, this is very important. This is within the cartilage. You are seeing an advanced disease, but there is a patient is having an airway compromise. What is the importance? Never take the patient for chemoradiation upfront. This is an absolute indication for giving an induction chemo program. Reassess, no dysfunction, take the patient for chemoradiation. So this is one. If you start the chemoradiation for this patient, after few fractions of radiotherapy, the patient has to undergo a tracheostomy. Then we have to replan everything. So never do that. And this is one of the situations we have to consider induction chemo. Coming to T4A disease, it's a heterogeneous disease. Extralaryngeal spread without cartilage destruction is also T4A. If the patient is having a thyroid membrane is pierced, cricothyroid membrane is pierced, it's T4A. A through and through cartilage is also T4A. Trachea, thyroid gland, esophagus, even extrinsic muscles of tongue from a supraglottic tumor, it is T4A disease. So I will take a few examples. One, the extralaryngeal spread. Here you have this is at the level of you are seeing the hyoid bone. Thus, the extralaryngeal spread is due to the involvement of the thyrohyoid membrane. So we can see a lesion here, and same, it's a very bulky disease even with an airway compromise. So this patient can be taken for chemoradiation program. There is no through and through cartilage. And again, another area you have to look is at the level of the cricoid cartilage and thyroid cartilage in the inferior aspect. If you look, this is the cricothyroid membrane can be pierced, the conus elasticus can be pierced, and this can gain access to extralaryngeal, very minimal. Okay, the treatment may not change, but it may be upstage from T3 to T4A. And this is a subglottic extension. You can see a lesion with extralaryngeal spread. So again, it is a T4A, but there is no difference in treatment. You can take the patient for a chemoradiation program. Now, the patient with the through and through cartilage, the patient is this, you can see a through and through. This is again a bony window showing, you can see there is a through and through cartilage and the extralaryngeal spread involving the strap muscles. This patient is not a candidate for chemoradiation program. To me, this is the only absolute upfront indication for doing surgery in laryngeal tumors. In all other situations, it can be managed by radiation or chemoradiation program. And this patient should undergo a total laryngectomy, a bilateral 2-3-4 lateral androlateral neck dissection, plus bar minus reconstruction reconstructive required, followed by a planned post-operative adjuvant treatment. In this group of patients, when you plan treatment, you have to bear a few things in mind. One, when you're seeing CT scan, what is the extent of skin involvement? That is number one. Number two, strap muscle involvement and skin and strap muscle involvement. What about the internal carotid artery? What about the thyroid gland? And what about the pre-vertebral fascia? These are all important when you assess CT scan in this cut. Okay, this can all matters in the decision making. So to summarize, if a patient is having inner cortex is T3, it is chemoradiation. If the patient is having through and through cartilage, it is surgery followed by adjuvant treatment. And there is no extralaryngeal spread, but outer cortex up to the outer cortex. This needs a close interaction with your radiologist, and this go for chemoradiation to go for surgery followed by post-operative radiotherapy. This is my last few slides. That is T4B disease, a very advanced disease. Is a lesion in the, you cannot make out whether it is from supraglottis or pyriform fossa if you have a very advanced disease. And in this group of patients, you can see a very lesion involving the extralaryngeal spread is there, the prevertebral muscle is involved, prevertebral fascia is involved, and you have the very close intimacy with the carotid vessels. So this is a T4B disease. To go for, if you had to go for a palliative radiotherapy or to go for palliative chemotherapy, that's also very important. So if the patient is having no airway compromise, generally they go for a palliative radiation. If there is an airway compromise, very advanced disease, and generally they are considered for palliative. So I will summarize for those who have joined late. Okay, so this is epiglottis. You are seeing at the level of the, I have shown you and discussed the how to look for various muscles in the floor of mouth yesterday. And this is epiglottis here. You have the epiglottis here. You have the vallicular, median glossoepiglottic fold here. This is a pharyngoepiglottic fold. The aryepiglottic fold here. You can see the pre-epiglottic space, the aryepiglottic fold here. And it is getting attached to the arytenoid cartilage. You are at the level of the folds cord. Now you are at the level of the true vocal cord because you are seeing the cricoid cartilage, arytenoid cartilage and cricoid cartilage. Now you are at the level of the subglottis because you are seeing only cricoid cartilage. Okay, I will take this I think this is last two CT scan. So this is a patient, a 74-year-old gentleman who has this at the level of the folds cord because we are seeing the arytenoid cartilage. You can see an enhancement lesion there involving the paraglottic fat. Here at the level of the true vocal cord, you can see that because you are seeing arytenoid cartilage, cricoid cartilage and thyroid cartilage involving the entire right vocal cord, involving the anterior and commissure posteriorly. And you can also make out erosions of the anterior aspect of the cricoid cartilage here. You have a subglottic extension here, extralaryngeal spreads minimal through the cricothyroid membrane, erosion of the inner aspect of the thyroid cartilage here with a subglottic extension. And I want your attention how to look for a subglottic extension in a coronal view. Here usually you should not see any soft tissue in the cricoid. Here you are seeing a soft tissue here at the level of the cricoid cartilage. For two things, coronal view is very important. One, to know where early paraglottic fat. Second is to know where is an early subglottic extension. These two situations you have to make use of the coronal view. Okay, so again, this is a lesion. This where it is T2, T1, very small lesion, but compared to the right side, you have a right paraglottic fat is preserved, but the left paraglottic fat is involved. So it's a T3 disease. How you look in the coronal view is, this is how you look. See, this is a right paraglottic fat here, very clear, you can make out, but the left paraglottic fat is obliterated. So it's a early paraglottic fat. It's a T3. So you have to upstage this. Why it is important? You need to add chemotherapy, and also on top of that, you need to treat the lymph nodes as well. So that is it. Then, and the pre-epiglottic space can also occur from oropharyngeal carcinoma extending into pre-epiglottic space, that becomes T4 disease. So to summarize the checklist for the imaging, one is the site of the disease, two the tumor oleum, size, pre-epiglottic space, paraglottic space, post-cricoid region, extension to subsides, anterior commissure, posterior commissure, cartilages, thyroid gland, superior inferior extent, prevertebral fascia, carotid artery, extralaryngeal spread, lymph nodes. You try to learn by yourself or entrust your radiologist report all these facts before deciding treatment. Thank you very much for your patient listening.
Thank you very much, Dr. Cecil. In the interest of time, I'm sure there are a lot of questions. We'll have a personal discussion with Dr. Cecil during tea. So we'll move on to our next session, neoadjuvant chemotherapy versus CTRT in laryngopharynx. It gives me great pleasure to invite Dr. Nandini Menon, Associate Professor, Medical Oncology from Tata Memorial, Mumbai.
Good morning, everyone, and I would like to, at the outset, thank the organizers for inviting me. So, the topic allotted to me was neoadjuvant versus concurrent chemoradiation in laryngopharynx, and for the purpose of this talk and interest of time, I'll be covering mainly the laryngeal cancers and hypopharyngeal cancers. So, Dr. Cecil had taken a great talk. The previous talk was on how we look at radiology and how we go about treating patients, and since it's already discussed, I won't spend much time. What we are going to look at mainly the role of neoadjuvant chemotherapy in organ preservation, that is laryngeal cancers where laryngectomy is indicated, but we would want to preserve the larynx because the larynx is functional, and a few patients where there is very advanced disease such as T4 disease and what its role is versus chemoradiation in such settings. Similarly, in hypopharyngeal cancers today, we try to preserve function wherever we can, that is in stage 3 and 4 disease with the functional laryngopharynx, and here the modalities include either concurrent chemoradiation or NACT followed by radiotherapy or chemoradiation. So we look at, so basically we look, in this talk I just try to cover about how the evidence has evolved over time and what is the future going to be. Is it going to be one versus the other, or are we coming to a new treatment paradigm with, of course, the incorporation of new agents such as immune checkpoint in these settings. So we know that the role of NACT in head and neck cancers in different subsites and sites, it has different value. The most widely accepted indication for NACT worldwide is basically organ preservation, especially in case of larynx. And there are a lot of debates on whether the NACT or induction chemotherapy really has additional benefit in terms of survival, and what is the benefit we achieve by subjecting these patients to toxicities of chemotherapy and delaying local therapy. And of course, the treatment paradigm as is evolving will change. We know also that in larynx and hypopharynx where there is locally advanced disease, but there is a functional larynx, and none of the features which Dr. Cecil had described which preclude organ preservation, CTRT is often used as a standard of care with certain patients where we consider neoadjuvant in certain scenarios. So, like it was discussed, what is the ideal candidate for larynx preservation either in a laryngeal carcinoma or hypopharyngeal cancers are not having gross cartilage erosion. It should have a baseline functional larynx, and these patients should be able to receive radiotherapy concurrent with chemotherapy, or if they are fit enough for neoadjuvant approaches followed by local radiotherapy. And of course, patients have to come for follow-up because salvage therapies need to be offered if these non-surgical therapies fail. And some patients select patients that have exolaryngeal disease without erosion of the cartilage, or may be considered for maybe induction chemotherapy approaches followed by larynx preservation. Of course, gross destruction of cartilage, dysfunctional larynx, poor performance status patients are not candidates for larynx preservation. And essentially, this NACT versus CTRT concept was mainly to preserve the larynx, which before the 1990s did not was the standard of care was actually a laryngectomy, which was again the loss of the organ. This basically is a slide which shows data from our center where they looked at patients with limited exolaryngeal disease and the benefits that they got in the local control, which they had in patients without and with cartilaginous involvement. So like we discussed, in patients where we can preserve the organ, surgical I will not discuss, they are in earlier stage disease. It's generally in the T3 plus and node positive disease where we look at either CTRT or induction chemotherapy followed by radiotherapy, and also concurrent chemoradiotherapy is another standard of care that is used. And what is the evidence that we had? What did these trials look at? Of course, the main focus of all these neoadjuvant versus chemoradiation trials looked at larynx preservation and laryngectomy-free survival and other important endpoints which we look at in head and neck cancers, locoregional control, disease-free survival, and overall survival. So this is some of the old studies which actually changed the treatment paradigm in patients, which moved from total laryngectomy in the late 80s, before the 1990s, to slowly preserving organ by using various approaches such as concurrent chemoradiation or neoadjuvant or induction chemotherapy followed by radiotherapy. The earliest was the Veterans Affairs Laryngeal Cancer Study Group trial, which included patients with laryngeal cancer, excluding the T1N1 disease. And this was one of the studies that actually showed that you can preserve the larynx without compromising survival. And then subsequently, this was again looked at in hypopharyngeal cancers, a similar study which looked at larynx or hypopharynx, where surgery versus neoadjuvant chemotherapy plus radiotherapy was compared. And then we had the RTOG 911, which looked at chemoradiation versus neoadjuvant therapy followed by radiotherapy, and compared it with radiotherapy alone, and looking at the value of chemotherapy in different sequencing to preserve the larynx. And most of the trials, these older trials, looked at platinum and 5-FU. Some of them later on had the tax studies added taxanes, and of course with better outcomes with the addition of a third drug, of course at the expense of toxicities. And they had some form of local therapy. So the veteran study had in the experimental arm radiotherapy after induction, and the other studies looked at radiotherapy after induction versus chemoradiation versus RT alone. So, and most of the other studies as well looked at 2-drug versus 3-drug induction chemotherapy followed by chemoradiation. So I'll skip this. So just like I said, this was the approach, total laryngeectomy evolving to a larynx preserving approach, and probably now we are looking at response adapted treatment approaches in patients with laryngopharyngeal cancers, where immunotherapy or chemotherapy can be combined, and then look at response adapted local therapy, and I will discuss them in subsequent slides. So I won't waste much time. I already discussed the study. This was the inclusion criteria T3 and T4, and the patients had to be fit, and the control arm was surgery. At that time, that was a standard of care, and this study was designed, and it looked at how you can avoid surgery and preserve the larynx. And this study showed that laryngeal preservation is possible without worsening the overall survival. So at 2 years, it was 68% in each arm, and there was a 64% laryngeal preservation rate. And even at 10 years, both the arms had a survival of around 22% without worsening of the survival when the larynx was preserved. And that is how we started using larynx preservation approaches. These are the curves showing the same. And then the other studies which looked at it. And now coming to chemoradiation and how it came into our treatment paradigm for cancers of the larynx. So this was the RTOG 9111 study, which was a landmark study which looked at different approaches. So it came a little later after the veterans group study, and it looked at the value of adding concurrent chemotherapy to radiotherapy and comparing it with NACT followed by RT as a way of preserving the larynx, and the one arm was RT alone. And what it showed was adding radiotherapy to radiotherapy concurrent chemo had definitely better outcomes. The primary endpoint was larynx preservation, and in this study, the concurrent CTRT arm had an advantage over chemo followed by radiotherapy. And it also showed that maybe adding chemo as an induction followed by radiotherapy may not be really better than radiotherapy alone. And you can see that if you gave CTRT, there was an 88% larynx preservation versus 75 and 70%, and even local regional control was better. But ultimately what they looked at 5 years and 10 years is that although your larynx preservation was much better when you give concurrent radiotherapy, and that is why we follow this quite often in our day-to-day practice, at 10 years and also at 5 years, there was not much difference in the survival. And there were multiple factors that they thought could be the contributing factors, and which is why, again, there are some concerns when we give patients chemoradiation and the toxicities related with it. So as a conclusion of the study, we know that concurrent chemoradiation definitely was better for organ preservation, definitely was better for the locoregional control, definitely was better. But in terms of overall survival, all three arms did the same. And one of the reasons the authors thought was because of the late toxicities of patients receiving concurrent chemotherapy dying due to non-cancer related or non-treatment related causes at 5 and 10 years. This is another study which also looked at laryngeal and included hypopharyngeal cancers, and showed that induction chemotherapy versus CTRT both were studied, and there was no difference in survival between the two, and either approaches could be taken. Here there was a slight difference where they had 5-FU cis followed by RT versus 4 cycles of chemo alternating with 2 weekly RT. And again, the Glottic trial, similar group of patients, but instead of looking only at PF versus RT versus CTRT or surgery, it looked at adding a taxane. And we know from this trial and other studies that taxane definitely added an advantage to organ preservation. But again, this did not show a survival advantage. So a similar study was done in hypopharyngeal cancers, where again, treatment of locally advanced disease would entail a pharyngolaryngectomy with the nodal dissection with loss of voice and function of the larynx. And a lot of times extrapolating from the laryngeal cancer data, NACT or induction followed by radiotherapy was used. And then this study was one of the URT studies done, which looked at organ preservation, and it is basically similar like the Veteran Affairs study, where they looked at stage 3 and 4 disease and randomized them to standard of care surgery followed by adjuvant therapy at the time, or gave them induction followed by radiotherapy. And again, it showed that you can preserve the larynx without compromising survival. So what it also showed is that a little advantage of neoadjuvant chemotherapy, like we expect for the distant metastasis-free survival, but the functional, so this is the, and the 3 and 5 year estimates for functional larynx was 42 and 35% in the larynx preservation arm. And this is the 10-year uptake. So to summarize, I'll not go into it. To summarize, both in laryngeal cancers and in hypopharyngeal cancers, the old studies which came in the 90s and early 2000s looked at organ preservation, where neoadjuvant therapy or concurrent chemotherapy added to radiation can actually help avoid surgery and preserve the larynx. And then there are, I'll just skip these slides, but these were the outcomes where we were able to preserve the larynx in a significant number of patients. And although adding NACT to radiotherapy or chemoradiation itself did not add to overall survival over chemoradiation, but laryngeal preservation was achieved. And of course, we have the McKenzie analysis, which showed the benefit of addition of chemotherapy in different settings. And we know, of course, in the concomitant chemoradiotherapy setting, it has the most value, especially in larynx and hypopharynx. But also, induction chemotherapy was used not just as an alternative to concurrent chemoradiotherapy, that is NACT followed by radiotherapy versus concurrent chemoradiotherapy, but induction chemotherapy has also been evaluated before concurrent chemoradiotherapy in some studies, which looked at using IC followed by radiotherapy in same group of laryngeal and hypopharyngeal cancers. However, just a caveat, it included some unresectable tumors as well, which were not amenable for larynx preservation. And again, these trials were actually testing the value of the taxane, and which showed a better OS and the laryngectomy-free survival when you added taxane as compared to cisplatin 5FU alone. So again, this is another trial which also the Transplants study looked at induction chemotherapy followed by either CTRT with cisplatin versus cetuximab CTRT. And the larynx preservation rates were similar in either arm, so as whether you give cisplatin, cetuximab or chemotherapy with cetuximab. And there were also studies which looked at NACT versus concomitant CTRT or alone for head and neck squamous cancer patients. And again, this debate of whether to give patients TPF followed by CTRT versus CTRT or was again studied in multiple studies. But a number of these studies included also patients who were high risk, included N2 and N3 nodal disease. And of course, although there were these studies, many of them did not show a difference in the overall survival, whether you use the NACT approach or you directly went ahead with chemoradiation. For example, the DECIDE trial, there was no OS benefit. In the other trials, there were no PFS as well as OS benefit. But both approaches have been tested. And in certain subsets such as N2 and N3 nodal disease, some studies have shown that it's not consistently reported in all studies, but they may be benefit in high-risk patients. So high-risk nodal disease, N2, N3C nodal disease, and of course unresectable disease, which was in the TAX 323, where unresectable disease received neoadjuvant chemotherapy and then went on to receive radiotherapy. And again here, they looked at the addition of taxane. But just to highlight that this was a heterogeneous study, it did not only involve larynx and hypopharynx, there were other subsites as well, but around one third of the patients included laryngopharyngeal cancers. So this is the same. So the conclusion is, what is the debate? Are we debating using NACT followed by RT, NACT followed by CTRT, or versus CTRT? So a lot of the older data suggests that concurrent CTRT has better locoregional control, it helps in better laryngeal preservation rates, but for some reason this has not translated into a long-term survival in terms of overall or progression-free survival. A lot of the guidelines in the Western guidelines, including NCCN and the ESMO guidelines, suggest that for larynx preservation, there is value of NACT followed by radiotherapy. But what is the role of NACT followed by concurrent chemoradiotherapy? There is some debate. And again, concurrent chemoradiation alone is standard of care in many settings. What do we do in our day-to-day practice? Again, in patients who are amenable for larynx preservation, concurrent chemoradiation is what we routinely follow. But like discussed previously, the certain specific cases like airway compromise, where we expect the patient might go into obvious stridor if they are not in stridor already, is one of the settings in laryngeal and hypopharyngeal cancers where we use induction chemotherapy. Also in patients who have, for the study which I showed from the radiation group from our hospital, where they looked at limited exolaryngeal spread in select patients where there is only exolaryngeal spread through the membrane without cartilage erosion. Those are some of the cases we do get references for induction followed by radiotherapy or concurrent chemoradiotherapy. And of course in hypopharyngeal cancers, large bulky nodal disease, N2 N3 disease, in which the primary is still suitable for preservation. Larynx preservation approaches are what we generally are, we discuss in the MDT and then offer some of these patients neoadjuvant therapy. There are concerns and criticisms to both approaches, whether it is either or whether these are going to get eventually combined and we are going to come to a better treatment paradigm with the advent of immune checkpoint inhibitors is still evolving. But what is all the Western literature and all the data that is available criticize the use of induction chemotherapy mainly because of not having an OS benefit which was seen consistently in all the studies. And the question is whether we are delaying local therapy and whether the use of these drugs, that is using a TPF or PF, made the patients unfit for subsequent therapy if they did not tolerate it well, or they would not tolerate the concurrent cisplatin that was used during chemoradiation in some studies. So these older studies of course used higher doses of platinum, and especially they used 100 milligram per meter square of cisplatin 3 weekly as an agent, as a radiosensitizing agent. So these were the concerns that they had, and the fact that it increased treatment time, and there may be dropouts during the NACT period, or patients may not complete the planned radiation. And although chemoradiation of course has a superior larynx preservation rate, there were concerns raised about late adverse events, including dysphagia, dependence on a tube for feeding, and other non-cancer mortality related causes. And of course when we use cisplatin, we know that there is, although it is not a large number, there are some patients who do have residual renal dysfunction, have metabolic syndrome and other issues related to cisplatin use in the long term, even with good disease control. So the whole question is, today with all the data that we have in the past 20 to 30 years, and with the new studies that are evolving, are we asking the right question? Is it supposed to be NACT followed by radiation versus radiotherapy, the main question, or are we looking at something else that we can achieve with lower toxicities, organ preservation, and of course better patient tolerance, and looking towards something like a response adapted therapy? And of course, we have established data for chemoradiation for neoadjuvant chemotherapy followed by radiotherapy, or neoadjuvant chemotherapy followed by concurrent chemoradiotherapy, multiple studies with the toxicity data and long-term survival outcomes. But are these new approaches going to sustain over time for mucoregional control, laryngectomy-free survival, disease-free survival, overall survival? It's yet to be seen. But there is some interesting data coming up in terms of using immune checkpoint inhibitors and looking at response adaptive therapies or delayed local therapy for patients in for larynx preservation. So I'll just highlight 3 studies which were presented in the last 2 meetings at ASCO. So this is one of the studies which looked at chemoimmunotherapy as a single treatment modality for larynx preservation. And this is something that is not standard of care. We do not use any kind of systemic therapy as a single treatment modality in a curative setting for larynx preservation, but this was the study that looked at it. So I'm just going to skip it. This is the trial schema. They looked at giving patients a platinum-based platinum taxane doublet, which was dosi and cisplatin, and added pembrolizumab for 2 cycles. The primary endpoint, they had a co-primary endpoint of disease control rate and a PAT-CR rate, which they looked at after 2 cycles. If the patient had any kind of a response or stable disease, they received 2 more cycles and they underwent imaging and a biopsy. If the disease progressed, of course, the patient would receive local therapy, that is standard of care, either radiotherapy with or without chemo or surgery depending on the extent of disease. And what they looked at eventually is those that had a PAT CR, they gave 4 more cycles of pembrolizumab and kept them under surveillance every 3 months, looking at a laryngoscopy and imaging, which is pretty strict surveillance, and then at recurrence again offer them the standard of care local therapy. And of course, those who did not have PAT CR after total 4 cycles went on to receive standard therapy, either RT, chemo or surgery followed by RT. So this is one of the interesting part of the study is it looked at eliminating completely local therapy. And I'm just skipping since we are out of time to the co-primary endpoint rates, and you can see that CR was seen in 21%, of course only 5 patients because it's a phase 2 small study with a very small number of patients, and the PAT CR was also seen in a significant number of patients. And they managed to basically achieve disease control, and also patients who received chemoimmunotherapy as a single modality did not have a tracheostomy or a gastrostomy during a post-treatment. So this kind of reaches primary endpoint, but this is a small phase 2 study. We can't change practice right now based on this, but this is an interesting approach for patients who we would like to avoid long-term toxicities. There is also data that have been presented for response adapted therapy, a little heterogeneous study population including HPV negative head and neck squamous carcinoma, including larynx, hypopharynx, oral cavity and other sites, where they looked at giving chemotherapy, nivolumab plus again taxane platinum, and planning radiotherapy based on the responses. For patients who had good responses, again they gave a lower radiation dose, and those who had less than 50% responses, they gave the standard radiation dose. About around a quarter of the patients were laryngopharynx, that is hypopharynx and larynx. So again, the study shows that there is a way to probably define our treatment better based on the chemotherapy response, and this kind of correlates with the initial assumption that NICT also helped us to bioselect patients who are likely to respond to radiation after the induction chemotherapy. There are certain other studies which are looking at other immunotherapy based neoadjuvant strategies. I will not go into them. And I think just a word on radiosensitizers in patients which we look at concurrent chemoradiation. Now I'm over time, so quickly we know that cisplatin is the standard of care, but there are multiple alternatives that have been tried. The one concern was 3-weekly cisplatin and the ability to complete 2 or 3 cycles that was needed, but we have the CONSORT data that shows that 40 milligram per meter square can be a good alternative, and it was actually better than 3-weekly in this study. So we also have options of adding a biological to cisplatin, and we also have alternatives now with docetaxel and others for cisplatin ineligible. So just to conclude in short is that with data that we looked at, neoadjuvant followed by radiotherapy can be an alternative to concurrent chemoradiotherapy in patients who are amenable for laryngeal preservation. But of course now things are evolving, and we may be looking at a combination of both neoadjuvant and concurrent, and of course response assessment and response-directed therapy in the future. Thank you.
Thank you very much, Dr. Nandini. We'll take those questions over the tea break. It gives me great pleasure to invite our next speaker, Dr. Umanath Nayak. He's been a mentor to many of us here. So his talk is on advanced laryngeal cancers, organ preservation versus functional restoration. Dr. Nayak needs no introduction. He's a HOD of Head and Neck Surgery, Apollo Cancer Hospitals.
Yeah, it's going to be a tough call after these 2 earlier presentations, but I'll try my best. Quite a mouthful of a title, right? Before I get into my presentation, I have a disclosure to make. I'm not going to be presenting any new data or new evidence. All the data and evidence is already at the fingertips of the radiation and the medical oncologists here, Dr. Kaushik, Vamsi, and all of you. I'm just going to look at things from a different perspective. That is from a surgeon's perspective, obviously. So please bear with me. All the data and evidence has already been discussed about, and you know about it. These are some of the landmark trials which essentially put surgeons like me out of the laryngectomy business. In the early 90s and well into the early part of the 20th century, these landmark trials firmly established concurrent chemoradiation as the standard of care for advanced laryngeal cancers. From doing about maybe 2 laryngectomies every week in the 90s and well into the early part of the 20th century, today we are restricted to maybe about 1 laryngectomy a month, if you are lucky. Why did this happen? Well, from the time Bill Roth did the first laryngectomy 150 years back, I don't think we surgeons have really innovated much as far as total laryngectomy is concerned. More or less the same kind of surgery which we have been doing for decades has been going on. In addition, it has been seen that right from the 50s until the 90s, there had been no significant improvement in the 5-year survival of laryngeal cancers. In general, all stages put together, laryngeal cancer survival was in the range of the 5-year survival was in the range of about 60 to 65%, and that did not change from the 50s till the 90s. So obviously something had to change. Something had to get better because all of the cancers, the survivals were going up. Why not laryngeal cancers? So people started questioning what else can be done. At the same time, this coincided with the time when a lot of new innovations were happening in the medical oncology field. Cisplatinum was a game changer. In addition to the development of linear accelerators and then progressing on to IMRT, IGRT, RapidArc and whatnot. So there was a tremendous improvement with chemotherapy and radiotherapy while surgeons were not able to keep up with these improvements. And also questions were being asked about the quality of life. The Halstadian days of remove cancer at any cost does not matter. You have to survive cancer. Were slowly phasing out. People were looking at quality of life issues. What kind of quality of life are you giving to these laryngectomy patients were being asked. It was generally considered that laryngectomy patients had a poor quality of life. An operation which was considered life-saving till the 90s suddenly was falling out of favor. Just imagine. I mean, I wouldn't say they were wrong. IT professional like this in his early 30s suddenly undergoes a laryngectomy. He cannot talk. He has a stoma. He loses his job. He has kids to take care of. Because of his stoma and his negative body image, he stops interacting with his colleagues and his friends. His social circle dwindles. He sits at home. He's depressed. He goes into isolation. Is this what? Questions were asked. Is this the kind of life you want to give to these people when you have an alternative? So at that time, naturally, concurrent chemoradiation became the standard of care for all advanced laryngeal cancers. And laryngectomies went out of fashion. I wonder how many of you during your college days have worn bell bottoms? I did. It was a game changer. Suddenly, everyone was wearing bell bottoms and it became a rage. In fact, your fashion sense was dictated by how wide your bottoms were. And then it was believed that this fashion is never going to go up. It's so popular. And one fine day, they just went out of fashion. Suddenly people stopped wearing. We do not know why it happened and how it happened. So it is believed that fashion changes every couple of decades. What is new becomes old. What is old becomes new. Apologies for digressing from the topic, but I suppose some of you might have got the message, what I'm trying to say. Coming back to the subject, in 2003, the National Cancer Institute released the SEER data for the 5-year survival of laryngeal cancers over a period of time. And to everyone's surprise, it was found that laryngeal cancer was the only cancer where the 5-year survival of patients had fallen down in that period between in the early 90s till the end of the century. Every other cancer, the survival was going up naturally with the improvements in technology and etc. Maybe the dip was very marginal, but a cancer which was expected to improve in survival had fallen down. So if you're talking about from a 68% 5-year survival from 1980 to 82 to 64% in 1992 to 99, if you're expecting this survival graph to have gone up, so if you add that to the fact that it has gone down, it was a cause for concern. Why has this happened? When people looked at it, it coincided with the time when chemoradiation became popular all over the United States as a standard of care for advanced laryngeal cancers. Now, surgeons are a little slow in understanding data, evidence, etc. But ultimately, fortunately, they did. But 5 years later, there was a huge debate, and a lot of journals came out with this debate as to why is this happening? Why are more laryngeal cancer patients dying than they were? There was an extensive editorial review in the Head and Neck Journal, and in fact, Arlene Forestier, who was the chief investigator for many of the organ preservation trials, also gave a very strong rebuttal. But it was evident that she also did express some concerns. Is there something not right with our organ preservation protocols? Does something need to change? So there were a lot of things which came out during that period in the early part of the 20th century, which continued on for a decade or so. And they did accept, all these protocols did accept there were a lot of issues which had not been properly addressed in many of these trials. Elderly patients, and they essentially those above 70. Are they in a position to tolerate chemotherapy? Is chemoradiotherapy the right protocol for them? Are they completing treatment? Are they dropping out of the treatment? Are they dying? Nutrition. The average American patient nutrition is quite good, but many of this, despite that, nutritionally being strong, many of them required PEG. And in some of these cases, the PEG could not be removed subsequently. So nutrition was a concern. Has this been addressed properly in all these trials? Demographic differences. For example, can you compare the results? Because in many trials in the other parts of the world, the same results were not being duplicated what was being seen in the US. So is there a demographic difference? Can the puny Indian tolerate a chemoradiation protocol as well as an American or a European? What about the Asian, the Chinese? All these things were not really addressed. What about race, ethnicity, etc.? So some of these questions were also asked. Can we use the same protocol for patients all over the world? And yes, we all know that it's very difficult to have a trial comparing primary surgery with CTRT. Only now in the recent past, in the last 10 years, we are coming out with trials which are comparing now finally CTRT with primary surgery. Of course, in those days, some of the things were probably pharmaceutical driven, so this was never really considered, but it is time to really do that. But during that period, no such trial existed, direct randomized trial comparing laryngectomy with CTRT in all aspects. And this is when the concept of the dysfunctional larynx came, which didn't happen in the 90s when the protocol first came out. It was realized that patients whose organ is not functioning, what are you really going to save? A dysfunctional larynx, in which there is aspiration, it was found that post-operatively too, these patients continued to have aspiration and they were never comfortable. Laryngeal edema, patients who had a tracheostomy prior to the chemoradiation protocol, they did not do well at all because they could not be decannulated post-operatively. Now let me tell you all that a tracheostomy is far, far worse than a laryngectomy for a patient. Both may have a stoma, but there's a difference between the stoma. For those who want to know more about it, can discuss with me during the tea break, but do not think that the tracheostomy and a laryngectomy patient has the same quality of life. No, not at all. So these were some of the things which had not been addressed, which now started being addressed. That today we know that in a dysfunctional larynx, you should not do the organ preservation protocol. And also there was a lot of post-treatment sequelae. These patients, especially I told you already about the fact that some of the larynxes were dysfunctional and they did not recover their function back. There were pharyngeal strictures. Patient had to be continued on the PEG if they had, or on rice tube feeding. And this was more, of course, with hypopharyngeal cancers, but in some laryngeal cancers too, there was significant pharyngeal strictures. And there was also a concern that all stages and subsites of the larynx had been lumped together in these protocols. Was that correct? I will elaborate on this subsequently in the next couple of slides. But ultimately, the conclusion was that in many patients, the larynx preservation protocol was inappropriate. The patients were not selected properly. The survival was worsening, which I already told you. The cost of treatment was increasing. And for example, it almost landed up with the investigator telling the patient that some of you will lose your life so that others will save their larynx. So it's a little dramatic statement, but yes, these are some of the things which were coming up because survival was becoming less, but more people were saving their larynxes. So like a gangster would say in a cowboy movie, your money or your life. It was like your larynx or your life. What do you choose? Coming to the stage group issue, let us look at this. Now this is a nice proliferative T2 supraglottic cancer, very much amenable to radiotherapy. You do not need organ preservation protocols for this. You do not need the standard chemoradiation for this. This is a classical T3 cancer, which of course is amenable for concurrent chemo RT, probably the ideal case. And this is a T4 cancer, which again will not respond to concurrent chemoradiotherapy. So you have three different modalities which are the right treatment for these three things, but all of them went into the organ preservation protocol into chemoradiotherapy. So these were not really studied properly. Individualized treatment was not available. Everybody, from sometimes even in the early VA trials, even T2 stage cancers were put into the organ preservation protocols. There was a tremendous poor selection of patients in many of these trials. Everything was lumped as one. T3, all types of T3, T4 and whatnot. So naturally, as investigations continued, trials continued, it ultimately was established in subsequent years, in the early part of like 2010 and 2000, around that period. This was an article which came out in 2017, which clearly said that for a T4 laryngeal cancer, organ preservation protocol is to be taken off. And this has been accepted by almost everybody today, that for a T4 cancer, once there is through and through cartilage invasion and there is a soft tissue extension, chemoradiation is not the right treatment for them. It was a big study of about 800 patients, but even questions were asked for T3 laryngeal cancers. And it was clearly noticed that there was a better 5-year survival rate for patients who were treated surgically in the range of about 65% to almost those treated with radiation with or without chemotherapy in the range of about 50%. So there was a significant survival difference even in T3 laryngeal cancers. Subsequently, there were other studies done in different parts of it. I put these studies basically because let us look at the studies in countries which have a similar incidence of head and neck and laryngeal cancers like in our country. I could not really get much of data about Indian studies, and although there were recent ones, but many of them showed organ preservation protocols to give something around a 45 to 50% 5-year survival. I would be happy if somebody can correct me and come out with any data which they have in the organ preservation protocol, concurrent chemoradiation in advanced cancers. But from whatever I got, it was always in the range of about 45 to 50% or even less. Although the American studies quoted about 65% plus. So similarly in France, again, which has a high incidence of head and neck cancers and laryngeal cancers, it was found in the recommendation conclusion in the study was that total laryngectomy is recommended as a primary modality of treatment for T4A. Primary total laryngectomy should also be considered for T3 laryngeal cancer patients with severe and irreversible impairment of laryngeal function with large subglottic extension invading the cricoid cartilage, or with contraindication to an optimal larynx preservation protocol such as previous RT to the neck, contraindication to chemotherapy, advanced age, poor general condition. Also, it also mentions that in addition to this, one should have a multidisciplinary management of laryngectomized patients, integrating intensive functional rehabilitation and a personalized therapeutic education program to improve quality of life and psychosocial well-being, which is a very, very important part of the entire plan. but ultimately tries to say that for a good subset of 3 as well as all T4s, the organ preservation protocol is not to be practiced. Similarly, another Brazilian study, which again, where laryngeal cancers are supposed to be very, very common. Again, patients with T4 tumors should have laryngectomy as a treatment of choice. And it is important to note that organ preservation treatment of the larynx does not always mean the actual preservation of a functioning organ. So ultimately, in essence, what we would like to say is that in T4 cancers, elderly patients with T3 disease, patients presenting with dysfunctional larynx, and patients with bulky nodal as well as primary disease, larynx preservation may not be appropriate, considering all these trials, studies, experience. Now, the question here is that the whole question of a laryngectomy came into the picture because the quality of life of patients was poor. So, if you are going to recommend total laryngectomy to a patient, and you tell him that you're going to lose your larynx, but your survival is going to be 10 to 15% more, would he still opt for that? Would he still prefer chemoradiation even if you told him in the rightly selected patient that your survival may be 10 to 15% less, but you're going to preserve your voice? Is laryngectomy such a terrible operation? So should we consider some other issues other than just survival figures? Well, let's talk a little bit about that. Now, there may be a lot of sequelae of a total laryngectomy, but primarily we're talking of 3 things: voice, pulmonary function, and the negative body image which occurs because of the stoma, or we call it the appearance. Now, finally, ultimately, surgeons woke up to the fact that they need to do something more about these surgeries. So, primary voice restoration became popular. You can actually right now put a voice prosthesis right at the end of your surgery, and 2 to 3 weeks after laryngectomy, patients can talk quite well. We have done some pioneering work too in this aspect. I've even written a book about it, which is being used as a guide by many people who would like to develop and learn the voice restoration techniques. So today you have this laryngectomy patient who was depressed, isolated, and now he has a prosthesis, he can speak, his life suddenly changes. He gets his job back, he can take care of his family, he can hold his head high in society. So things change a lot for laryngectomy moment they have their voice back. They are no longer isolated, they interact socially, and they start moving out. But is voice the only thing we are looking at when you are looking at a laryngectomy patient? No. We believe in comprehensive rehabilitation of the laryngectomy, which includes not just physical, voice, swallowing, but also psychosocial, emotional, all these aspects also come into the picture if you really need to get them back on track. So, a comprehensive laryngectomy rehabilitation program is what is mandatory in order to get them back. Just a small word about pulmonary rehabilitation. A lot of laryngectomy patients, this is a frequent complaint they have a lot of cough, sputum production, and they are very uncomfortable with that. But the use of this simple device such as an HME filter can make a big difference to these patients, and studies have shown that this significantly reduces the amount of difficulties they have with this lungs. The pulmonary function seems to improve significantly, and this is an important aspect of our laryngectomy rehabilitation too. Lastly, about the presence of the stoma, we feel that it may be having a negative impact on patients. Yes, it is very difficult to really imagine that. There are a lot of studies which have shown that, which have compared laryngectomy with organ preservation protocols, but it's difficult to imagine really that a laryngectomy patient can actually have as good a quality of life as a person whose larynx is intact. So some studies have been done, but we also did a small quick study about the appearance of the stoma, and we found that a patient who has a comprehensive laryngectomy rehab program, who spends enough time in our laryngectomy rehab group, ultimately stops feeling self-conscious about his stoma. And this study showed clinical significance significant differences in patients who attended our comprehensive rehab program regularly and those who did not. It was found that those who attended the laryngectomy rehab programs did not feel stoma to be a negative body issue, and it is basically they got used to it and they were able to interact socially and they went out, and that did not seem to bother them anymore. So for those who have been napping, just one summary quick, that total laryngectomy with primary voice rehabilitation and post-op radiotherapy is the standard of care for T4 laryngeal cancer. Current evidence supports chemoradiation for a majority of T3 laryngeal cancer in an institutionalized setting. And in the presence of a comprehensive program, a subset of T3 patients, which every day is increasing, this subset is gradually increasing day by day, should be motivated to undergo a laryngectomy. And we heard about radiological importance in staging that cancer. For example, if you have a T3 cancer and you think it is a T3 cancer and radiology tells you there is a subtle erosion and you have missed it of the thyroid cartilage, it has gone out of the cartilage, then it is not a case for organ preservation protocol. Similarly, a T2 cancer, which is actually T2, and then you think it is T3 because you not assessed the patient properly, may again not be a candidate for organ preservation protocol. So it is important to have clinically and radiologically thorough evaluation of the patient before you put them into the protocol. If as a radiation or a medical oncologist you cannot really evaluate these patients, it is good to have a surgical colleague to assess the patient, clearly stage it before you put them into the protocol. And a wrong selection of patients for chemoradiation may ultimately jeopardize the larynx program. And God forbid that Amitabh Bachchan starts wearing bell bottoms again. Just a quick minute.
Hi, my name is Mohammad Farid Khan, and I had suffered carcinoma of vocal cord in 2004. 2005 April, I went through this laryngectomy surgery, and after around 1.5 months, the prosthesis was fixed, and since that time I've been using regularly, without any HME and direct, with the finger. I learned this voice control and it's much easier. Personally, I did not feel using direct larynx because it gives a kind of robotic sound. So the sound quality and wordings is much better. And life is normal. Except only one thing which I miss, I cannot swim anymore. No more swimming in the deep sea or in rivers or anywhere. That's the only restriction I have in my life. Life is normal, eating, everything, enjoy, moving on. And the biggest thing is that which I appreciate is the support, the family support, the social support, the working atmosphere, the friends, colleagues, everybody supporting. That's all for today. Thank you.
Thank you for your patience.
Thank you, Dr. Nayak. Any questions for Dr. Nayak or Dr. Nandini?
Among the audience, I think I have the unfair advantage of working with Dr. Nayak for 15 years. So I cannot tell you how important this presentation was. It is so easy to be seduced by the prospect of having an intact body part. At the same time, it may be so easy to demonize the loss of a body part. The truth is far, far more complex than that. It is till you actually see a properly rehabilitated laryngectomy patient, you fail to understand the importance of comprehensive counseling, pre-selection, and delivering the best quality of life. Especially this is for the radiation oncologists who are so hung up and excited about the prospect of organ preservation. Organ preservation does not give you anything unless you have done a function preservation. Please be careful about knowing which patient of T3 will not benefit from function preservation. T4 is clear cut. T3 is where I have seen especially younger people, because sometimes they don't have the support of a good surgical oncology head and neck team with a good rehabilitation program. If you think that you are not doing justice to these patients, please understand that not only you have to change, you have to get a good surgical head and neck guide. And I mean, this has been the expectations of so many of us. This is one of the most valuable lectures that we have heard. Thank you.
I mean, I know the practice is not going to change once you're out of the hall, but it's good to keep things in perspective. Just hear it from the other side too. Thank you.
Thank you, Dr. Naik. We will
Excuse-
take a short break for. Oh, you have one more question.
Yeah, I just want to add one point to the sir's lecture. That is that most of the patients with this larynx preservation program post the treatment, we also see a kind of a breathy voice where their voice is not much of an audible, and they may not be improving much with the voice therapy also, because this vocal cord adduction affected after the radiation because of this edema. So we also struggle a lot to actually improve their voice, and they will be also having an aspiratory events post treatment of this post laryngeal preservation program. So I just want to highlight this point. Thank you.
So we'll take a short break for tea for about 10 minutes, and then we'll resume our program.
Welcome back everyone after a refreshing high tea. So let's move on to the next session on radiation of oropharyngeal cancers, impact of P16 by Dr. Trinanjan Basu, Senior Consultant and HOD, Radiation Oncology, HCG, Borivali.
Good morning. Thank you, AIG team, for the kind invitation. So this will be the roadmap of my presentation. We know already in oropharyngeal cancers the role of HPV and how it has changed staging and also the treatment implications. They are two very different cohorts. One hand, in P16 we are going towards more and discussing more of treatment de-escalation, whereas we have definite concerns with P16 negative, which is the bigger cohort for us with the current treatment protocol because of the failure patterns. And are there any steps to enhance the disease outcome, especially in P16 negatives? We know that we can skip this P16 positive negative, the clinical features and how they impact, what are the sites, what are the clinical features, what are the treatment implications. I have tried in my presentation to keep more or less Indian data because I'll come to that why that is also important to know. Now, long back, about 6-7 years back to back in Indian Journal of Cancer and then South Asian Journal of Cancer, there are these two articles of the Indian data of HPV, both from TMH, and we can see the majority is P16 negative. The P16 positive is a very rare cohort for us. From the north and southern parts of India also, there are isolated data. So across all the data, we come to this, that oropharynx HPV positive is ranging between 15 to 23%. The predominant sites are base tongue, tonsil, soft palate. These are the three main articles highlighting that. Now, recently there have been a meta-analysis also, and even if we have P16 positive, it is often negated by the smoking history and the tobacco association, which is very common for us. So this systematic review from India tried to see that why we lack, even if we have HPV positive data, which is also rising in certain cohorts in India, but still lower than Western countries. Since tobacco remains the main causative agent, even if we have P16 positive, they are presenting in advanced stage, node positives, and eventually, in spite of P16 positive, not everyone has a good outcome. So we may not be seeing what Kianang has seen, the typical low risk, intermediate and high risk for P16 positive, because most of the time it is negated by the tobacco association. The tobacco association also been proved by the March HPV project. So once you have a classic P16 positive and never smoker or tobacco association, then only you can see in the curves how their survivals are changing. The moment even with P16 positive you have tobacco association, it is dipping in the curve. Now there's a perspective to it. This is a recent one on oral and oropharyngeal, the P16 data and how the clinical features and the treatment paradigms are moving. So they are moving in this way. If you are HPV positive or P16, then we are trying to maintain the survival data as well as more investing into QOL, organ preservation, and how to de-escalate treatment. Whereas in the other end of the paradigm, if you are HPV negative, we really are still struggling to improve the survival data. So the other aspects are taking a back seat. Now, let's talk briefly about P16 positive. We all know of these three trials. They basically tried to challenge the standard treatment with replacing the concurrent regimen and in some also changing the dose. So all were, in fact, after this meta-analysis been proven, we all know the data is out, that the standard treatment by cisplatin-based chemoradiation remains the standard of care as of now, even in the low risk cohort of the HPV P16 positive. Replacing cisplatin also had poorer outcome of that. So then what next in P16 positive beyond this de-escalate and the RTOG 1016? So these questions came up from that. Was the rationale of de-escalations rightly been selected? And what actually patients want out of it? Is HPV risk grouping being done accurately, taking the clinical and pathological features? What important lessons we learned from that, and what would be the future framework? This Red Journal issue then highlighted these 4 influential clinical trials to be important in P16. Now what they have done, Orator, we all know it is a TORS versus plus adjuvant versus the radical CTRT. Keep in mind the aim was dysphagia in this. Then the avoid, which is a post-TORS scenario of avoiding the primary site radiation. Then the Mayo Clinic trial is again post-TORS, then pathology guided radiation and radiation dose reduction, and the UNC UFL study with reduced dose radical chemoradiation. By all these, nothing is actually finally even conclusive out of it. So if you read this review by Perry Blanchard some time back, it is very nicely written that it is still going on. This is about 5 years back, and still lot of data is going on in Western countries. Eventually, in spite of the randomized control trial, failed to show any benefit of de-escalation. That also brings to a question, is de-escalation only limited to reducing radiation dose? At times the de-escalation trials looks like just reducing radiation but adding up so many other modalities. So are we really de-escalating things or reducing one modality and by that time adding another modality? So at times a disease which were curative, having a good control by two modalities, we are reducing one modality and adding eventually a trimodality treatment. So are we really de-escalating anything in this? This also led to resurgence of TORS with several trials and also some immunotherapy based trials as well. This brings about a different aspect which the different editorials from this has highlighted, that cure remains the highest priority, and this has been done long back on different patient questionnaires. So if you counsel a patient and tell them that the survival will be detrimental even less than 5%, then almost 70% of them would refuse de-escalation. So this is one very important aspect to keep in mind. To end P16 positive, we have this recent in PRO, the Astro consensus guidelines on the HPV positive oropharyngeal cancers. Most of these points been discussed often in different articles, whether it is a radical CTRT scenario or a post-TORS scenario, where to select which modality, what volume to select, what would be the important organs at risk and their concerns. So in conclusion of that, and as a future direction, the standard radiation with cisplatin as a radical chemoradiation remains still the most important treatment modality, even in HPV P16 positive. For cisplatin ineligible, there will be further trials which are already going on. For the low risk HPV cohort in early stage, whether there is a need of an optimal systemic agent, only future trials will answer. The NRG HN005 and Keynote 412 have gone further ahead, adding concurrent IO to it, and we know the ECOG 3311 have started a pathway of pathology guided adjuvant treatment after the TORS. In comparison to that, all the guidelines in oropharyngeal, especially in a P16 negative cohort, which is a more common cohort for us, are more or less remain the same. Most of the time the P16 negative end up receiving most of the time receiving radical chemoradiation. We do have an Indian guideline also to it in oropharyngeal cancers, both for the early and advanced with P16 positive negative, and if you look carefully, most of the time the radical chemoradiation remains the standard of care, so as in NCC and P16 negative. Is there a role, as these guidelines highlight, for surgery in T1, T2, N0? So the look at all the databases, there is some role, but the data is very limited. So even in the orator trial, 12% of the people were P16 negative. There are different challenges of TORS or TLM in that, and I'll come to that. So we all know the orator trial, 88% were P16 positive. They had at 1 year the dysphagia QL by the MDADI scores and radiation scored over surgery. Then people tried to do orator phase through, which eventually got closed due to the unwarranted side effects in the surgery arm. Now, still there are a lot of transoral robotic surgery data in HPV negative because it's a poor cohort. But look at the toxicity rates in that. So that often becomes a concern for that. And even in HPV negative, if they're undergoing a TORS, the survival also again changes depending on the T permutation combination. So is there still a role of TORS in HPV negative? So among all these data available, there was an RTOG trial which got closed due to poor accrual, and the biggest debate is between the trimodality therapy and a poor local control. So eventually TORS in an HPV negative would end up adding an adjuvant treatment, most of the time a chemo radiation. So we are eventually not saving anything, and the margin status is still a debatable thing. In for P16 positive, it's debatable. Negative anyhow is a larger mucosal spread disease. So we eventually are not gaining anything by that. On the other end of spectrum, we have more or less standard guidelines for the chemo radiation for long back across the disease stage, T and permutation combination, where to select the single modality in early stages and the moment node positive adding a concurrent chemo. Many times we hear from our surgical colleagues whether an N1 actually needs, yes, it definitely needs adding a chemo. It is proven from the older Glottic study to the Astro recommendation and the last one of the Zoomstegs data from NCDB analysis. So even an N1 adding a concurrent regimen definitely fares better. The role is also proven across HPV positive or negative, as the T stages remain important. For a T1, T2 adding a concurrent, it didn't lead to translate into any survival benefit. Moment going to T3, even N0, definitely there's a benefit of concurrent regimens. We also know from this older Dr. Vedang's data that in India, because the tobacco remains predominant, even in P16 positive negative, neither of the parameters, be 3-5 year survival, showed a statistically significant difference. So we deal with tobacco associated cancers. From an earlier cohort also of the Breaky trial from TMH, with the similar survival at 3 years, this is a predominant T1, T2, N0 HPV negative cohort with the 3 years overall survival around 65%, which is similar to the Western data of ICON and the NCTB database. Now, more or less, all of us as radiation oncologists have moved on to IMRT. It remained a standard RT technique compared to 3D CRT. We have long-term data from India for that. We know the xerostomia dysphagia data also from the Breaky trial, and the DERS data also trying to spare the dysphagia optimized radiotherapy, with the caution that they hardly see HPV negative. So the HPV negative cohort is very less in that. So this was on a favorable cohort more or less to do all these, which is not the reality for us. The reality which matches closely, as Dr. Nayak was saying, from the French, because they also see more or less a similar cohort. So this IGR data have analyzed the progression things in HPV negative. So if you see the loco-regional only, which will be only about 5% in P16 if positive, goes to almost triple if P16 negative. The first site of disease recurrence also loco-regional, mostly for P16 negatives, and at 5 years there will be a 50% less survivals with P16 negative compared to the positive ones. So our biggest concerns is loco-regional recurrences in an HPV negative. Also, this is also a bigger concern. We hardly have Indian data to prove. If you do a PubMed search and do all these booleans, we hardly have two datas. One, Nandini is here, their nimotuzumab cisplatin and radiation data, which is quite encouraging for the HPV negatives, and the second is Dr. Indranil's, their data from TMC. So it is a predominant HPV negative cohort with, you can see, only 20 patients were P16 positive among the tested. So there were a 40% of them which are not tested, and we all know the reasons. There are a lot of challenges. We see patients from different sectors, which is also true in the TMH Breaky data. About 35-40% people were not tested. So a predominant P16 negative cohort, and you all can see the survivals, how it is differing. The sites as per the global literature available, and with an acceptable toxicity rate, the radical CTRT remains the standard. This year's Astro, we have a poster discussion of the P16 negative data from my institute. So we had about 140 patients in that, and our P16 positive rate on the tested ones is just 9%. So those are not counted in this, and we also have seen a similar kind of survival. And in fact, in P16 negative also, between T1, T2 versus T3 N plus, there is a difference in survival. And that's due to these local recurrences. We know there are 3 most important sites of the local recurrence in oropharynx, and there are IMRT specific failure patterns also. Is it really that bad? So that's very difficult to answer, because if the biggest data, the most promising is from the Brian O'Sullivan data from PMC, where the 3 years local control is around 80%, and across India, whatever data is available, our local controls is also between 70 to 80%. The trials somehow don't pick up in P16 negative of doing a TORS versus then risk adapted treatment, because we see mostly advanced stages. So most of the time these trials get closed. There are several challenges with P16 negative, the lack of data, try to find a novel therapeutic option like the P16 positive, and different permutation combinations of systemic agents. There are a lot of research, although in P16 negative, since it opens a window of opportunity of adding different targets, different inhibitors, adding from the Dahanka group, as they are always known to add an hypoxic radiosensitizer. So their data, we also know the hypno data, it is not limited to the oropharynx, but trying to reduce the overall radiation duration and to get an initial result of a similar survival. Some microbiome data, and as usual, there has to be an immunotherapy data, although the initial results are all negative. There are some encouraging trials of phase 1 only of certain agents also in P16 negative. So probably sometime down the line we'll get to see any result out of it. This to me seems the most interesting thing. The phase 3 randomized trial of the best of the trial is called between TORS versus IMRT. This also though has a caveat of including T1 hypo and supraglottic. Both TORS, TLM and even conventional surgery is allowed, but the in nodal status only up to N1 is allowed. So this probably gives some answer in future for even HPV negative ones. So to conclude, the HPV definitely had changed our staging, our treatment approach and decision making, but we struggle still with HPV negative cohort because we deal predominantly with tobacco related oropharynx, which is a real concern for India. We definitely need a better way to predict them, and till that time it is very important to follow standard guideline and don't iatrogenically add local recurrences. And collaboration remains the key. I think out of these conferences, as radiation oncologists, we should really try to collect our P16 negative data and try to publish as multi-institutional. So I am a proud alumni of RGCR. So till the time we get some justice and some answer out of it, I can hope and pray for a better future. Thank you.
Any questions?
Thank you, sir, for an insightful session. Now let's move on to panel discussion on laryngeal cancer, chaired by Dr. Sujana Priya, Consultant Radiation Oncology, AIG Hospitals, Hyderabad. Our panelists for today are Dr. Trinanjan Basu, Senior Consultant Radiation Oncologist, HCG Hospitals, Mumbai. Dr. Prabhakar M, Consultant Radiation Oncologist, Sai Sindhu Hospitals, Hyderabad. Dr. Hemant Nimade, Consultant Head and Neck Surgeon, Indo-American Cancer Hospitals, Hyderabad. Dr. Krishna Chaitanya, Associate Professor, Medical Oncologist, MNJ Hospitals, Hyderabad. Dr. Snigdha, Head and Neck Surgeon, Sindhu Hospitals, Hyderabad. And Dr. Aarti, Assistant Professor, Radiation Oncology, MNJ Hospitals, Hyderabad.
Very good morning, one and all. So at the outset, I would like to welcome all my panelists for today's discussion. So we have 3 radiation oncologists, 2 surgeons and 1 medical oncologist on the panel today. So keeping in line with the brand, the AIG deep dive, so we are going to, this is our first edition and we are going to kind of do a bit of a clinical scenarios with the nuanced decision makings. So we'll slowly dive deep into the clinical based scenarios. So, okay. So the first case for today, so we have a 75-year-old gentleman with presented with hoarseness of voice, VL scopy suggestive of proliferative growth involving the right vocal cord extending onto the anterior commissure. So he underwent a laser excision in March 2024. So the biopsy was suggestive of squamous cell carcinoma. In May 2024, he was kept on follow-up, and in May 2024, he underwent a repeat laryngoscopic examination, which was suggestive of a local relapse. So this is the local relapse on laryngoscopic examination. So now, what would be the further plan of action? Dr. Hemant?
So, first thing is what was the intent of laser excision, whether it was a biopsy or it was a curative excision. So, I will like to go to, contact the previous surgeon and understand the previous intent, because it is very difficult to rely only on the pathology report.
Okay.
So that is one thing. Then imaging, endoscopy if the vocal cords are mobile.
No, the VLS has been done. The VLS has been done. It's a local relapse. The vocal cords are mobile. It's a T1 larynx.
Yeah. So still, I feel that if imaging is not very contradictory to the clinical finding, we can still go for laser re-excision and get the clear margins.
Okay, so your treatment of choice, next further plan would be repeat laser excision. Okay. So the repeat laser versus radiation. So radiation oncologist, Dr. Thiranjan, do you want to add something to it?
I will ask why in the primary the disease was going to anterior commissure. So what was the need of doing the laser at that time? I don't think we get any clear margin the moment the disease reaching the anterior commissure, but we can't go back to that. But my question would be, because it's a limited local relapse and with cord mobile, so already has undergone some botched up laser, what voice quality we are going to give to the patient by doing a repeat laser?
Okay, wonderful. So having said that, I'll just hold you at that. So laser excision, radiotherapy and microlaryngeal surgery, these are the three reasonably good options for early glottic tumors. Now, like Dr. Thiranjan rightly pointed out, so we are basically looking at two very important outcomes in this particular scenario. One is oncological control and the other thing is voice quality. So having said that, so we have very good evidence telling that the oncological control is not different, both more or less it's the same, be it laser versus radiotherapy. But what about the voice quality in this particular patient? So we have a very interesting Finnish paper published in 2014 looking at the voice quality comparing the two treatment modalities, laser versus radiotherapy. So the main outcome measured on this particular paper is GRBAS, the grade, the roughness, the breathiness, asthenia and strain. So for a lot of students who are standing out here, so there will be definitely be a clear vocal cord defect caused by carcinoma, and also because of the laser excision. So we usually have a greater defect and the voice quality is quite compromised and impeded. So the other thing is, this paper has concluded that for a better voice quality, definitely radiotherapy is the treatment of choice. And anterior commissure tumors, there is definitely a problem. So the problem, what do you think, Dr. Snigdha, about the problem here?
This is glottic webbing, sometimes seen post excision of anterior commissure lesions, but it may not happen always. It can be prevented by doing a staged excision, or some people would like to put a silicone keel between the two cords before sticking. I would agree with sir that both of them, that if prior excision was done with margins adequate and there's a local recurrence at the same site, then probably my threshold for sending it to RT would be less. I would rather send it to radiation therapy if it was adequately excised with margin.
Okay. So the key points here in this particular, the key takeaways here in this particular case is we just have to look at the oncological outcomes. There is no difference in oncological outcomes, be it laser or radiotherapy. But the key point here is the voice quality. The voice quality is definitely better with radiation, like we discussed the reasons why. So because of the webbing, there will be the loss of pliability of the vocal cord movement and it will impede the further voice quality. That is the main issue. And like Dr. Snigdha pointed out, and it is very much operator dependent, the way how you do it, and very much operator dependent. It is a very, very narrow area, the anterior commissure. Today morning, Dr. Cecil was actually talking about all those things. So So better to go ahead with radiotherapy is what we would think here. Okay, next the question is, anyhow this patient has gone with radiotherapy. Dr. Prabhakar. So what do you think, how do you like to treat this patient? What technique would you adopt in treating this patient? It's a very fairly simple T1 larynx.
So even 3D CRT is better with better local control, and fractionation we used to go for 2.5 gray per fraction to total dose of 63 gray because it's T1 disease.
Okay, wonderful. So this is exactly what Dr. Prabhakar has summarized. So these days, hyperfractionation has become the norm in T1 glottic cancers. So previously they used to treat, go around 6 weeks to treat all the laryngeal tumors. But these days, 4 weeks of treatment, 4 to 5 weeks of maximum treatment is enough. So not more than that. Even the NCCN, or if you look at the ASIA guidance, more or less suggests the same thing. So this is the clear-cut evidence behind which we kind of came to this conclusion. Conventional fractionation is no more the norm, especially in T1 larynxes. So this is a very interesting meta-analysis of 1700 patients. Yeah, Ati.
So I would like to add, now the evidence is growing for VMAT even in early glottic cancers, where of course I agree 3D CRT and VMAT have got no difference in local regional control, but there is evidence growing for sparing carotids, sparing thyroid as well, thyroid gland. So why should we be, causing radiation-induced hypothyroidism? Although I cannot really, quote proper evidence now, but the evidence is coming up and growing.
Yeah, Dr. Kaushik, yeah.
I will tell the evidence that you were looking for. So, so it is basically coming out of the latest contouring guidelines, which is the so-called 5+5 guideline. And in T1 larynx, you don't do 5+5, you just do 5. Just discussing as it is being discussed, that you basically draw the unilateral cord and give a margin. What it does is that it increases the sparing of the opposite cord, resulting in better quality voice, better tolerance. Also, it definitely cuts down on the carotid dose. Carotid is one of the most underreported toxicities in head and neck radiation. It increases the narrowing of the carotid. It can increase the incidence of stroke in the brain, and we don't really actually look at it because somehow we think that it's not an important thing. Having said that, there is a small caveat to it. There is always people who have done, including us, when we have started doing T1 larynx with one-side cord-only, I don't know how to put in English, one-side cord-only radiation. We have always been afraid of, is it a very, very small volume? It is really a small volume compared to what we have been doing as a student. And there is one Belgian review paper that actually echoes that sentiment and asks everybody to be very, very cautious when you are doing a T1 larynx, hemilarynx radiation. These patients who have done hemilarynx, you have to be very, very closely following them because of the higher chances of recurrence. It's a caution, there is no data for it, but it's a caution arising out of common sense. And then in that case, you will have to offer these patients salvage surgery.
Okay, yeah. Sorry,
anterior commissure involvement, you mean?
Yeah, Dr. Tiranjan can answer, yeah.
So actually anterior commissure involvement traditionally we treat by radiation.
With radiation, yeah. So the reason why we've discussed before.
So like Dr. Kaushik is saying,
I will give the answer to this. The traditional concern about anterior commissure lesion not doing well with radiotherapy has come from the time when larynx patients were treated with the help of cobalt machines and pre-treatment planning days. And cobalt has got a sparing of the skin of about 0.5 centimeter. When you do that, the anterior commissure would often get underdosed. But this was never detected because you did not have competitor sparing. In the current day, even if you're not using an IMRT, even if you're not using anything, you can easily see what is the underdose in the anterior commissure. You may have to add a bolus to bring the dose up. The concern for anterior commissure not doing well radiation is a 20-year-old concern. In today's context, it doesn't hold any real meaning.
We have experience with helical P in early glottic cancer, and the results were quite bad. So we had a number of local recurrences,
So we couldn't really figure out the exact reason why, because it was a carotid sparing study, like you mentioned. It was not like we were not careful. I mean, one of my so-called research project in my fellowship in Canada was on imaging in early glottic cancers, and we realized that the glottis moves a lot during treatment. So we were very cautious. But there are certain technical planning aspects, especially in certain modalities like tomotherapy, which is, treating slice by slice, where you would have to be doubly careful. Because if while, a particular slice is getting treated, the tumor is here, and the next slice is getting treated, the tumor moves up, then you could miss. And there are certain planning, how to, draw the dummy structures, etc. So doing very, like you mentioned, very selective IMRT in early glottic cancers is something that should be looked at prospectively. You should report your outcomes, audit yourself before you actually venture it.
Can I add?
Yeah,
something?
please.
So basically here it is not about surgery versus radiation. It is why it is failed. The previous surgery, why it is failed. And when we analyze that, we have to evaluate the patient properly, because anterior commissure as such is not a contraindication for laser. In a expert hand, we can get a clearance. And moreover that, surgeon has the advantage of getting exact nature of the disease. Like you get to know how the tissue is getting cut. So you are intraoperatively you are getting the feedback whether your disease is contained or not. So first is your imaging. Before taking a patient with anterior commissure, you should be very diligently image the patient so that you can know whether it is really involving cartilage or not. Second thing is your examination, whether the disease is touching anterior commissure and we can get margin or not. Sometimes the tumor will go vertically, and those tumors are bad. You do surgery or you do radiation, those tumor will be bad because they become they grow vertically in the anterior commissure. So there, what was the reason for failure, that we have to understand, and then we have to plan.
Probably, like you mentioned, the expert hand. Probably, we don't know. Let's see. I mean, like I said, there's a lot of caveats in doing a repeat laser. One is the impediment of voice quality, and other thing is the experience of the expert hand. So maybe they didn't go deep enough. We don't know. We don't know the exact reason as to why, but these are the possibilities we could probably elucidate.
Second thing is 75-year-old man.
Yes.
You are not going to give him a radiation without a biopsy in second stage also. So,
yeah.
Laser doesn't take much more effort than biopsy. Like you can do, if it is amenable, then only we should commit on the laser. Otherwise, you should get a biopsy and send him for radiation. So it is it is not versus. It is surgeon should take a call that it is not curable by laser, and then it should be limit his extent of excision.
Okay. Okay, so the only question we were asking is just whether what modality would you prefer? That's fine. We'll move on to the next case. Okay, so the key takeaways here are, so hyperfractionation has become the norm in treating T1 laryngeal tumors. And again, the voice quality is the key. You have a discussion with the patient and then move forward with whatever treatment is feasible. So now quickly moving on to the next case. So we have a 75-year-old male presented with hoarseness of voice, who's also a known diabetic, underwent a PTCA in 2022. So as soon as he found that he had a hoarseness of voice, the first investigation he underwent was a CT neck. He immediately got a CT neck, which were showing some few sub-centimeter nodes and also a right vocal cord growth. So the biopsy was taken eventually. So the VLS examination, this case, the VLS examination was performed outside. So they said the tumor is kind of localized only to the right vocal cord, and they've got a biopsy done, and he has got no aspiration, no dyspnea or no stridor, no other symptoms elsewhere. So with those reports, he actually came to the clinic. So basically, we were very excited. It was a T1 laryngeal tumor as per the VLS findings, So somehow we got a bit suspicious, and we got a VLS examination done, repeat VLS examination done in our hospital. So these were the findings of the VLS. So there's a proliferative growth involving the right vocal cord, again extending up to the anterior commissure with hemilarynx fixation. So all of a sudden there is a quite a bit of a change in the staging of this patient. So from the clinical stage T1A, it has kind of jumped to stage T3 N0. So because of the hemilaryngeal fixation. So now, my question is to Dr. Hemant again. So what parameters do you usually document at VLS and why? Wherever you take up a patient.
So VLS, actually we should examine the patient video, not the images,
Okay.
because it is a dynamic study. If it is a very superficial lesion, then we should gain more knowledge with the stroboscopy. And proliferative superficial lesions, stroboscopy may give us a little more knowledge. Then now vocal cord mobility is a very basic, like it has to be, we should be very cautious that whether the vocal cord sluggishness is because of the volume of the disease, and that vocal cord is not able to move because of it, or there is a fixation of vocal cord. So it requires, it takes some moments of diligent observation of video, so that we can get the difference between sluggish and fixed vocal cord, and the micro aspirations. So during there should be, we should see for the whether there is a micro aspirations that are happening because of the growth or because of the fixity of the vocal cord.
Okay, so
and any other lesions in the
Rest of the-
adjacent area that.
Yeah, Dr. Sigda, please add to this.
Just another simple manner of making the patient cough would give some idea about arytenoid, whether the fixity is due to the arytenoid fixation or the paraglottic space involvement.
Okay.
But that's ideally done under GA, but under VLS, asking the patient to cough might give a clue.
Okay, thank you. So, so how does it impact your treatment decisions? Documenting all these parameters, I think we kind of spoke about it as to how. Dr. Sigda, do you want to add anything as to how it impacts your treatment decisions over here, or you're okay with what Dr. Hemant? You agree with Dr. Hemant? Kind of agree with Dr. Hemant. All right. Okay. So now the question, the $1 million question again, surgery versus radiation. Now we know that this is a T3 N0 larynx. It's non-metastatic. We have done a complete staging. It's non-metastatic. Now, the question about surgery. So partial versus total laryngectomy. So does this patient, this question is for Dr. Snigdha, does this patient fit in for open partial laryngectomy or supracricoid laryngectomy? So what are your selection criteria? Just in case if you're going ahead with surgery.
If I'm going ahead with surgery.
Yeah, what is your selection criteria, or does this patient fit in for?
If the arytenoid is not fixed, he will definitely be a candidate for open partial laryngectomy. But having said it's T, because I may not able to avoid a single modality treatment, I would send the patient for radiation.
Okay. Okay. So what is your selection criteria? Can you please elucidate on your selection criteria for?
So one cord mobile, one functional cord is a with cricoid free. That is a minimum requirement for any partial procedure. So for this patient, most of the time now the partial laryngectomy open procedures are replaced by the endoscopic procedure. Like you can do extensive resections by laser. Particularly this patient is not a suitable candidate for partial laser excision because it is a posterior lesion. So that way, and as Dr. Snigdha has rightly said that he will require adjuvant because of it is T3. We may not go for the open partial, rather than we'll give a trial of and volume of disease is also less. So that way we can go with the non-surgical organ preservation.
Okay, this is actually an anterior lesion. It's kind of anterior going onto the commissure. If you just go back. So this is not like very posterior. Yeah, sir.
Yeah. So basically, I don't think there's much of a discussion in this case about a partial laryngectomy. There's a paraglottic spread. There is a fixity of the vocal cord. Unless you plan some very fancy procedures like you said, supracricoid laryngectomy, aspiration, 75-year-old man, you're going to make his life miserable. In fact, the question about partial laryngectomy should have come in the previous case. Post laser excision, recurrence, there was a scope for a partial laryngectomy in that case because it's still a limited disease. A hemilaryngectomy or a partial laryngectomy would have been ideal for that case if for any reason you do not want to subject the patient to radiation. Once it goes to T3, T4, unless you are in a center where you are doing continuously just for surgical practice, I do not think a partial laryngectomy should be done, such as, there are standard partial laryngectomy procedures for up to T2 and very early T3s. Beyond that, those things like cricohydropexy and all that are relegated to the textbooks these days. Some centers may do it, but there are a lot of problems with such surgeries.
So sir has clearly elucidated everything in detail. So this is exactly what the next slide says. Moderate T2 or small T3, just in case if the patient is fitting the criteria, limited to 1/2 of the larynx, limited to supraglottis without paraglottic space involvement. That's exactly what Dr. Naik was talking about. So most data, my data scoping was only as a radiation oncologist, so you can correct me if I'm wrong. So most data is from a lot of cases rather than randomized controlled trials, and the decision has to be taken. The decision has to be taken in an MBT based setting, and also the surgeon has to be quite well versed with doing all these kind of procedures. Okay. So now quickly, anyhow, we have kind of taken the route of radiation. So now Dr. Aarti. So radiation doses. So how do you treat this patient? What are the doses? And any more additional considerations you would like to think about while treating this patient?
So I'll go for conventional radiation with an IMRT or VMAT technique, and that is 66 gray in 33 fractions, 2 gray per fraction. And because I don't know of any data which supports hyperfractionation advanced laryngeal cancers. What additional considerations?
Okay.
Yeah, definitely concurrent chemoradiation.
Okay, fine. So the question is about, we can, yeah.
Can I step back on that question and ask, why would this patient not be a surgical candidate? Total laryngectomy candidate. Why not a total laryngectomy for this patient?
To see functional organ preservation. So freeze would definitely help in this case. You see whether the patient is aspirating or not. 75-year-old with comorbidities and all. Maybe is a candidate for total laryngectomy, but it has to be a functional organ. Then you consider for organ preservation.
Oh. So we assess your key takeaways. You assess the function of the organ, whether it is a functional larynx or not.
It is the functional organ which
it's a functional larynx because clearly we just mentioned a few symptoms that these symptoms are not there. So it's an indirect way of telling that it's a functional larynx.
Yeah, I also thought so. We have defined the functionality.
Function anyway in the first discussion itself. Yeah, more than that's exactly where we are coming to. Yeah, so 75 with multiple comorbidities, adding chemotherapy. We don't have much of an evidence beyond 70. The benefit of chemo is kind of not so much. Maybe Dr. Nandini can add into it once we come to the chemo part of the discussion. But still, I think more than beyond 70, the benefit is not very great, to be very honest. So now, like Dr. Aarti already summarized, I think a moderate hyperfractionation is probably a good way to go about it. That's what exactly we follow here. 65 to 66 gray in around 2.16 to 2.2 gray per fraction with a typical 5+5 approach. So Dr. Thiranjan, do you think you add something here for what Aarti has already spoken about?
No, pretty much the same. We also do this, and at 70 in mostly 2.12. Yeah.
Okay.
Same fractionation. The concern would be maybe sending to Medonc, whether they'll be able to give cisplatin, non-cisplatin based.
Okay. So the only thing is, additionally, we would be just treating the neck because it's a T3N0. Because the risk of occult nodal, so there's a very interesting systematic review showing that the risk of occult nodal metastasis is around 15%, especially once your T stage is going to go up. So now the key takeaways of this particular patient is the importance of VLS in assessing your treatment options, because it will definitely upstage just in case if there is immobile cord or hemilaryngeal fixation. And surgical selection, Dr. Nayak has very nicely elucidated the candidates for surgical selection. And organ preservation, if it's a functional larynx, that's what we have to emphasize. Yeah.
So this is probably a case wherein the decision should be left to the patient. As far as counseling, a good counseling is required because he's 75 years old. You are probably not going to give chemo.
Yeah.
It is total laryngectomy versus organ preservation. I think all the facts should be put clear to the patient. Do you want survival? You want your larynx or your life? So, I mean, I would like to know from the radiation oncologist in a T3 larynx like this in a 75-year-old without chemo, what would be a 5-year survival rate?
So this is the exact debate I was trying to bait, but none of the surgeons took the bait. Your decision to treat this patient with radical chemoradiation is primarily based on the Arlene Forrester data. Now, Arlene Forrester data, we all are very happy with the publication. Most of us fail to understand that there's a 10-year follow-up on the Arlene Forrester data, wherein they have shown that the curves which were separating initially actually have coalesced. And there has been a lot of speculation as to why the long-term survival of the concurrent chemoradiation for T3 patients has failed to sustain over time, and why there have been excessive deaths over time, so that the data points have merged, the curves have merged. And it is widely speculated that the main reason for that is because of aspiration-related additional deaths in those arms. And this patient is 75 years old. If this patient comes to my clinic in the MDT, I will fight tooth and nail to keep this patient in the radiation arm. That said, scientifically, I know that there's still going to be a caveat in this argument that, it's not always black and white. Yes, at 75, if you do a TL, the patient's voice prosthesis take up and artificial voice will also be a challenge, which is why this decision is going to be extremely nuanced. You definitely do chemoradiation for this patient, but don't think that you have totally saved the patient from the clutches of the surgeon. No, the patient may still require, a bad larynx will also always end up in a salvage laryngectomy, which is possibly worse. So it is not as straightforward, but I'm fending for the surgeons here. None of you took that bait.
Just want to make one point here that discussing here in this forum is a complete different ball game than discussing in front of the patient who is kind of already there worried hearing the word cancer and losing the voice or losing the larynx or saving the life, surviving for 5 years at 75 years. All this is a complete different ball game. As Umana Naik sir said, a proper counseling is essential, and I really don't know what could be the outcome of the counseling to the patient. He or she may take it as per their convenience.
Yeah, Dr. Indranil wanted to make a...
No, you're omnipresent.
Yeah.
You're omnipresent. We're not dismissing you.
We're just getting there. We're getting there.
I want to ask Nayak sir the reverse way. Even if this patient, okay, we understand all the points about not having a good larynx, having high risk of aspiration. Even if undergoes surgery, it is not a single modality anymore because it's T3. But eventually it might come. So how come a PT3, if it comes at PT3, how can you keep single? If it upstage 100%, if it upstage to a CT3 going to PT4A, of course, but traditionally for all radiation oncology and all guideline, T3 is a stage 3, sir. Why there is no data? Because it is never evaluated. T3, there have been never any trial of selecting a proper T3 between surgery plus minus adjuvant vis-a-vis doing a radical RT or chemo.
No,
RT.
that's what I'm saying. Larynx is one organ where the standard protocol for a stage 3 cancer does not hold because you're removing the entire organ with the disease inside. Unless it has come out or there are nodes positive, generally the recommendation for a T3 laryngeal cancer is total laryngectomy alone, no adjuvant RT.
Okay, so we'll move on to Dr. Krishna Chaitanya. So your opinion about adding just this, so anyhow this patient underwent radiotherapy, your opinion about adding chemotherapy here in this particular patient?
Yeah, concurrent if the performance status is good, the organ function is good, definitely weekly I would prefer rather than the high dose cisplatin 100 mg. 40 mg per meter square would be comfortable. If he is even not eligible for that, maybe you can give an option for nimotuzumab. There is some data. Otherwise, just definitive RT.
Okay, thank you. So I think we'll quickly move on to the next case. I think we're just running short on time. So the next case is a 64-year-old gentleman who presented with a hoarseness of voice, cough with sudden onset of shortness of breath and noisy breathing. So in view of those symptoms, a CT neck was done, which was suggestive of a soft tissue in the supraglottis with destruction of thyroid cartilage and cricoid cartilage with significant luminal narrowing. So biopsy was done, squamous cell carcinoma, and the staging was performed, which was suggestive of no evidence of disease. So what is your preferred line of management and why? Dr. Snigdha?
Could you just go back to the previous?
Yeah, sure. So this is the report given by the radiologist. This is CT neck. So that is where the tumor is. So suggestive of a lesion in the...
Yeah. So this would become a T4A larynx, 64-year-old and dysfunctional. So I would go for a total laryngectomy followed by adjuvant radiotherapy plus minus chemo.
Okay. So because it's a dysfunctional larynx, you would obviously proceed with the TL, total laryngectomy with neck dissection. Yeah, T4A, yeah. Based on the radiological findings. Okay.
Only thing I will add to it is if the scan is there, patient is in breathing difficulty, I will counsel the patient for total laryngectomy, and I may not do only the biopsy. I will pre-counsel the patient, and after frozen, I will like to do total laryngectomy in the same setting if the frozen is positive. Because doing if patient requires tracheostomy after biopsy, de-escalation biopsy, it will be little, I will be more comfortable doing laryngectomy in same setting. So if the patient is in stridor or patient is in breathing difficulty and you are expecting that you may require tracheostomy during biopsy, I may counsel the patient properly and take frozen plus proceed.
Yeah, okay, thank you. So this question is for Dr. Chaitanya. So the patient is an overt stridor. So any role of NACT plus or minus IO, now that I know IO is everywhere, it's become ubiquitous here. So even in head and neck, we know that there's a role. Now Dr. Nandini has already shown us a lot of evidence. So what would you prefer, any role of NACT in this particular?
No, in this case, I don't advise. Maybe directly going for a surgery would be an ideal choice. But wherever we are considering for a organ preserving procedures like giving us radiation therapy, not in this case. And in those cases, I would prefer an ACT, but not IO at this point of time. I would just prefer, if the patient is fit enough for a tax based regimen, I would prefer an ACT in that case.
As in induction?
Yeah, induction or sequential also.
Okay. No, he's just... Yeah.
If it's organ preservation, we do have like patients who have airway compromise, potentially impending stridor, and our radiation oncologist after the MDT refers. So we have given some patients like that. Routinely, we don't give immunotherapy to everybody. 1 or 2 we have given selectively, those who could not take the TPF regimen. Another thing we are doing alternatively, and that's like on a case-to-case basis, is we use a weekly paclitaxel carboplatin and either add metronomic to it or add immunotherapy to it in those who are not fit for TPF. It's not standard of care because we yet don't have a randomized evidence for it. But a lot of those who get the triple metronomic and paclicarbo, our surgeons and radiation oncologists are very happy because the response rates are very good. So this is anecdotal, it's not a randomized data. Though we are exploring it in a borderline resectable oral cavity, we have not done it in larynx and hypopharynx. So if TPF is not an option, then these are the other 2 alternatives we use, but not as standard of care. It's on case to case.
So what is, I'll add to that. So what is happening in the space of neoadjuvant immunotherapy these days? So are we following it, or still in the trial setting, or?
So, majority in the trial setting. Phase 3 trials for resectable oral cavity are likely to get completed soon. For larynx and hypopharynx, we still have to wait for a little while for the data to be available. So far, we have not yet had any trial in our center, but on a case-to-case, we're using it. We don't use it for all as a standard of care right now, but probably it might become in select populations in the future.
Probably.
Maybe wait for larger populations, because whatever data were 20 patients and 40 patients, so eliminating or response directed therapy. Now I don't know if there is any data yet for its impact on that's yet to be seen, so we don't have that data yet.
We've got very encouraging results with Keynote 48, but that's not relevant here because it's in the metastatic setting. So, okay, anyways. So, of course, this patient underwent a total laryngectomy with bilateral neck dissection. The final HP is squamous cell carcinoma with inner cartilage of thyroid involved on the final HP. So, 1 out of 40 nodes positive, no extranodal extension. So the final HP came out to be T3N1. This is actually a real case. So again, Dr. Hemant, so would your management have changed if you knew it was a T3 tumor with a functional larynx?
In this patient, not. If it would have been a supraglottic tumor with very proliferative growth, and there was a doubt on FIS, whether there is a functional or not, because of the volume, the patient is whether the aspiration is because of the volume of the tumor, and that time maybe I would have gone with the NACT arm. But if it is a glottis, we are sure that the cord is fixed and it is a dysfunctional.
And it's a dysfunctional larynx.
It's a dysfunctional. Then then there is no confusion. But if that dysfunction is because of the volume, then there very select group of patients with very careful monitoring that can be done, and it is not a generalizable.
Okay, so I'm just clearly not going into all the data because we've already discussed 9111 VA study and all before, from our speakers before. Tax 324 has also been discussed by Dr. Nandini. So now quickly just jumping into the adjuvant treatment options, Dr. Thiranjan. So what are the adjuvant treatment options you want to offer for this patient?
Since it is T3N1, then we'll end up giving adjuvant RT to post-op cavity and bilateral neck node. Since no ENE, then adjuvant radiation alone should be okay.
Okay, Dr. Prabhakar, what are the doses you want to give for this particular patient?
Yeah, we'll go with conventional fractionation. For primary, we'll go 60 gray in 30 fractions, and we need to know the level of the lymph node involvement. So that comes under intermediate risk category. So I'll go for 54 gray and low risk 46 gray.
Okay. So do you think there is, Dr. Aarti, do you think there is any role of hyperfractionating in this particular patient? No. This is what Dr. Prabhakar has already summarized.
No. No.
Okay. So, okay, only conventional. Wonderful. So we don't have any evidence as yet today, in today's day and age, that there is hyperfractionation really helps. But at the same time, there is individual patient data meta-analysis which showed that hyperfractionation with twice daily with concurrent chemotherapy has kind of superior to other things. But the statistics is a bit too much overwhelming in that particular paper. But still, for now, in the adjuvant setting, there is no role of hyperfractionation. The benefit is not there because of the rate of high acute reactions. Dr. Chaitanya, any role of adding concurrent chemotherapy in this particular patient?
Only if it is extranodal extension is there, then I would go for concurrent.
Yeah, this is standard RTOG and the Bernier and Cooper trial, so there is no added benefit, so we'll just go with adjuvant radiotherapy alone. Finally, we've come to the conclusion of the panel. So early larynx treatment, you need to have a quick insight as to which modality is better. So the decision has to be made on the location, the bulk of the disease, your voice preferences, and the compliance to follow up. This is very important. Especially, there are a bit of gray areas, especially with respect to T3 larynxes. We had a very good discussion with all the head and neck surgeons over here. So the intermediate and advanced laryngeal cancers, the decision has to be quickly made on larynx functionality, which is the most important factor in deciding whether you're taking the route of organ preservation versus you're taking the route of surgery. And fitness for surgery and fitness for taking further adjuvant treatments is also the key in your decision making process. And last but not the least, the rehabilitation, which is quite understated everywhere, that has to be the key. So it should be taken precedence and follow up, and the rehab, the speech and language therapist has to be involved from the beginning whenever you take all these decisions. Thank you so much. We would like to see you again in January 25th and 26th. Please block your calendars. The AIG Summit second edition, we are coming very soon, and you will get a flyer very soon. Thank you so much, and I thank all my panelists for your encouraging participation. I will look forward to seeing you again soon. Thank you.
Thank you, panelists, for an informative and an engaging panel discussion. Next, we have AI in Radiation Oncology, Future Beacons by Dr. Indranil Malik, Consultant Radiation Oncology, TMC, Kolkata.
Let me thank the fantastic team at AIG for inviting me here. And I have to say, I'm just spellbound at the hospital. So thank you. I'm really happy that I'm here. So I have this red question mark at the end of the topic as to, what is AI in radiation oncology? How is it going to disrupt our care, or will it in, the near future? Before I begin, I just like to know how many people here are radiation oncologists. Can you just raise your hand? So plenty. Okay, thank you. Because I was a bit worried that in a multidisciplinary session, I might bore many of you with AI restricted to radiation oncology. So I know that many of you are young oncologists, and believe me, these terms, I don't know whether you know and understand them already, but you have to, because a great percentage of what you're going to read in papers, by vendors, everybody, they're going to talk about this. Okay, so very simply, data science, which is, the big, like India, yeah. It means using data for decisions. Okay, any kind of data. You analyze your paper, you're using data science, right? So that's data science. Now, when you want to learn something from that data and use that data to make predictions without specifying a particular formula for using the data and the numbers, and you want to give some examples and make a computer program understand the examples and give you a prediction without giving it a formula, without giving it a particular pathway, then that is called machine learning, right? So machine learning is a subset of data science. Now, we all know that, when we used to doing statistics, we have T stage, N stage, size of tumor. These are parameters that we have to read out, from an image, or from, a pathology slide, or, from the look of the patient, right? But we have to get that data, we have to code it. And you give, coded information, a limited number of coded information to a particular program, and it generates a prediction. That's relatively simple for the program or the system to handle. But we know that, our coding or our, extraction of data by humans can be prone to fallacies. It's simply not detailed enough, and it can be dependent on, interperson variability. So what if we just give the image to the program, just give the pathology slide to the program, just give the entire NGS to the program? Okay, now that is dealing with a lot of data. And normal methods of statistics and simple methods of machine learning are incapable of dealing with that volume of input parameters. So to deal with that, you need a different kind of machine learning, and that is known as deep learning, right? And at this moment, over the last 5 years, I've been giving talks on AI for the last 5 years, things have changed completely, and nobody talks about machine learning anymore. Most of the things that are being done now are being done with deep learning. And we also have a specific type of deep learning, which is known as generative AI, where you are not asking for any prediction at all. You're asking, by giving a small input, you're asking the program or the algorithm to create something. Create an image, convert one line to an MRI, convert, write a poem, write an essay. So that is creating something from a relatively small input, and that is known as generative AI. So with this background, let's proceed. Okay, so AI is a subset of data science that includes machine learning, deep learning, and generative AI. Now, this is a pictogram of what radiomics is. That's another term that at least the radiation oncologist has to understand. Okay, radiomics in the classical sense is using an image, but not using deep learning. Using an image, running a computer program to extract a few or a few hundred parameters from it, using mathematical modeling, and then using those parameters into a machine learning model which can accept a limited number of parameters, right? And you can use that for segmentation, or you can use that to make predictions about outcomes and toxicities, etc. But that was the old thing. That was, by old here we mean 10 years old, which is not old at all for some of us. But now we don't do that. What we do is that we give the image, and all this information is extracted, and what is known as a convolutional neural network will extract the data and take it into the prediction level. Okay, so radiomics in the classical sense is a bit old, and modern radiomics doesn't use the radiomic features, objectively. It basically uses convolutional neural networks to make the predictions. Okay, so when we assess an AI application, we have to see what is the impact of an AI application. Now, if you are going to critically assess something, you have to see that what does it actually do? Does it just reduce the time, but is not at human level yet? Does it improve on human performance? Does it actually lead to clinical benefits like improving adverse outcomes? Does it lead to improving survival outcomes, which is the ultimate goal of any, good application? And on the other hand, you have to also look at other things like, does it require substantial supervision? Is it safe enough to be left on its own? Or do you need to actually check and correct everything? And finally, what is the impact on our work? Will it take away jobs, or will it make us change the way we do our jobs? Okay, so we'll come back to this slide later, but let's see what AI can do in radiation oncology. So can AI disrupt the process for the better? Can AI help choose patients for better treatments? Can AI help us do our technical stuff better? Can AI predict outcomes and toxicities? So where are we now in this process? Now, as you all know, at least the radiation oncologists all know, that AI has made its biggest advances in segmentation or contouring, as some of us call it, and a little bit of a progress in treatment planning. Now, till a few years back, most of our systems had what was known as atlas-based auto-segmentation, which basically took another person's contours and tried to deform it into a new person's contours with very poor results generally, right? But now that has completely changed. In the last few years, what is known as deep learning based auto-segmentation has come into the market. Deep learning based auto-segmentation uses convolutional neural networks, usually neural networks that are called U-nets. The architecture is in the shape of a U and does a pretty good job. So deep learning based auto-segmentation consistently outperforms atlas-based techniques. And, I'm pretty sure that all of you have seen examples, gone to websites, seen demos. And these have been able to, do a reasonably very good job in delineation of what are known as organs at risk for those who are not radiation oncologists. So they are pretty good now. Yeah. So we spend a lot of time contouring. In a few years, we won't be spending that time. Now, in terms of autosegmentation progress for organs at risk, it's more or less a solved problem, but there are a couple of things that you need to be aware of. First is that you may get a program that is being sold to you, but you need to check it on your own CT data. Okay. You have to look at the costs and the availability, the integration with your systems. You have to also check whether there will be continuous improvement in its accuracy. That are they going to give updates on a regular basis? And finally, are they going to accommodate changes in practice guidelines? What is contoured as structure X today, that guideline may change, and therefore is your program going to adapt? Now, in our hospital, we have, we are very interested in AI, and therefore we thought that, okay, we are not going to buy any model. We are going to develop our own. Okay, so what we've done is that with a team from IIT, we have actually used open source tools to develop our own model, which we call as DRAW. Okay, so, and it so happens that it turned out to be a pretty easy task. And we have 3 anatomical sites, prostate, brain, and breast, where this is used for every single patient. And we modify it, it's not perfect, but it was not a difficult problem for us. And models are being generated in head, neck, rectum, and lung. And we are hoping that in a year or a couple of years, we will have all our sites, where we will be using our own deep learning autosegmentation model. Now, this was the first evaluation. This is a video from the first evaluation of a prostate cancer model. It's not head and neck cancer. And you can see that just with a relatively few cases, it's not perfect. There are some problems, but it learns very well from your data. So if you have, so what this basically means is that this will become absolutely commonplace in just a few years' time. But there is a problem, and the problem is that for the tumor itself, we are considerably further behind. Okay, that's because this is a far more complex task. Delineating the margins of the tumor is completely different ballgame altogether. In some sites in the head and neck, there is a greater chance of this happening in the near future. One of them is oropharyngeal cancer. Because oropharyngeal cancers generally, it's easier to demarcate it from the surrounding normal tissue compared to other sites. And this is a 2021 challenge in MICAI, which is a computer society that deals with this. And they found that, some programs using deep learning were doing a reasonable job. Still not perfect, still will require a lot of human intervention. And to my knowledge, there aren't very robust systems that are being sold to, draw tumor delineation. It will be a completely different ballgame in sites like oral cavity, sites like larynx, sites like nasopharynx, because using CT scans, you cannot do this in these sites. You will need MRI integration, and an entirely new challenge will open up at that point. In brain tumors, tumor segmentation is much more robust. Yeah. What about treatment plan? Now, traditional automated treatment planning, what we used to call automated, was either a rule-based implementation, a knowledge-based planning, which took lots of examples from the past and developed shortcuts to do it, or what is known as multi-criteria optimization. So these were 3 pillars of what used to be known as automated treatment plan. Now, what we realized in our experience was that you can predict DVHs very easily by giving certain small inputs like the volume of the tumor, the overlap region, volume of the organs at risk. And most of this work has been done in prostate cancer, but I am reasonably confident that it can be done in head and neck cancer as well. And if you give these inputs and if you work a little bit harder, you can actually, what you can do is you can prescribe individual dose constraints. You know that, the spinal cord dose will be met with this patient. How low can we go? Okay. So you can predict these things easily using, a summer intern, or sometimes if you are interested in doing this yourself, you can do this yourself. This was done by a fellow, a radiation oncologist, and myself. So this can be done. Yeah. But now there are deep learning based approaches, both machine learning and deep learning models, which are used in head and neck cancer treatment planning. Unfortunately, this is not an easy task. The reason for this is that treatment planning is an iterative process. What the medical physicist does is that it looks at the first output, it changes the priorities and the parameters, and keeps playing with it until a certain goal is reached, right? So, but there is progress that is being done. Now, this is again a small project that we did, never mind. But what we are seeing coming out very recently is that there are deep learning models which can replicate this process. So this is a paper, recent paper from Johns Hopkins and I think UT Southwestern, where what they did was they sequenced two deep learning models, one known as the parameter net, which uses some planning scores to decide which parameters to change in the treatment planning, and a second model known as the action net to decide how much to change it. And by iterating it, it completely automated the treatment planning process. And to assess it, what they did was they participated in a competition known as the planning challenge, where the best physics team, dosimetrist team were participating, and they scored really high, and in some of the parameters they had the highest score. And then they compared with their own clinical plans, and they found that this method was giving them better plans than their own physicists, and these are very, very good centers. So while this is a new paradigm, things will start moving. And there are, vendors coming out with automated treatment planning methods. And so the physics workspace is going to get challenged as well. Now, the question remains as to, these are all going to be expensive. How are we going to deal with this? There are, centers like MD Anderson, which have started what are known as community service, automated treatment planning, and their radiation planning assistant. What it does is that it auto segments, it lets you do the CTV segmentation, and then does auto planning or generates the parameters for a rapid arc plan and gives it back to the center. I'll come back to this later on. Now, in terms of radiotherapy quality assurance, there are again some models which are helping in both machine specific QA and patient specific QA. I won't go into a lot of details because I'm pretty sure that not many people will be interested in it, but they are getting better. They're definitely not clinical grade yet. So let's come back to a bigger question. Will AI help us predict outcomes and make better and faster decisions for patients? Now, a generative AI project that we are participating in, or we have started, is what is known as the MDT Next. Or basically, if you give people the text of the pathology report and the radiology report and the clinical findings, will it give you the treatment recommendation? Right? So this is a relatively simple project, and and we have initial data which shows that it's relatively easy to do, and we can do it for head and neck cancer if we work a little harder. And there's a grant which we are aiming for, and hopefully this will become a pretty commonplace thing in the future. But there have been also prediction of outcome research. And this is the same MICAI challenge that I told you. It had several parts. So one of the parts was, what is going to be, can I predict a particular survival outcome from a PET CT image of a patient who's getting radiotherapy? And again, this shows that we are making progress, but we are not there yet. We can't very accurately predict outcomes using current technologies. But predicting outcomes can be done in a relatively simpler manner. If you know the hand-coded parameters that you want to use, you can, using nomograms and dashboards, predict survival. And one of the key elements of doing that is that you can also use some machine learning methods to augment what are known as clinical methods. And we have, started on a certain direction to try to see whether we can do that for our oral cavity patients. Toxicity prediction is another, goal that some of these machine learning models are trying to deal with. But there are many challenges with clinical implementation, one of them being lots of data required, consistent annotation, very importantly, external validation. And to do that, we need what are known as multi-institutional data sets. A few years back, we created India's first oncology image bank, which we are trying to, make a multi-institutional image bank. And we also need to validate or test these models in a very careful way. So the archery study that I mentioned is actually trying to do that in a multi-institutional, multi-country setting by testing the MD Anderson model in several hospitals. And Tata Memorial Mumbai and us are a part of this study. And once you have a model, say suppose you have created a model, how do you easily test it on data from several hospitals? You can do it by what is known as federated predictions, like there are federated learning models, what are known as federated prediction models, and you can host them in servers like MedPerf so that other people can test your models on it. So I'll come back to the slide that I started off with. In many of these goals, we are still stuck at a relatively early stage. We've got things that are close to human level, but not there yet. And we are still dealing with, a situation where you need substantial supervision, where minimal or no supervision is not possible yet, except for some types of segmentation. But in the future, things will, evolve, and we will need to modify ourselves. So I know that Kaushik doesn't like memes, but this is a meme that we have to deal with, is that, we look at AI as something that will solve all our problems or make or automate everything, but we really don't know how fast we are going to get there or what are the real, goals that can be achieved with AI. But we will eventually need to adapt to a slightly different role, from actually doing things to evaluating and supervising automated processes through AI. And we have to learn how to do that through our careers. I mean, nobody here is very old, so we all have to learn how to do that. So I'll leave you with this, and thank you very much.
Any questions from the audience?
Thank you very much. I'm surprised that you don't have any questions. If I were sitting on this side, my first question is that, will I lose my job? Nobody's bothered about this? Nobody's bothered about losing your jobs?
I think I believe AI will result in a loss of jobs in radiation oncology. There's no doubt about it. The reason is that we are a very technical field, and some of these things that we spend time on right now will get automated. And at some point, people will realize that it's cheaper to get the software than to get the people. So one of the things that you understand is that if you think that you are good because you're good at contouring, then you're certainly going to lose your job. Okay, because it's not something that you're going to do many years into the future. Okay, so you have to become good doctors. You have to learn how to interact with patients. You have to know who to treat in what way, rather than just restricting yourself to techniques. So actually, the emergence of AI is a call to all of us to just become better clinicians, because most of the non-clinical part, the AI will take care of. In the medical sphere, the person who's the least likely to lose his or her job is the nurse. Because very few AI, I don't see any nursing AI replacing nurses. So the more time you spend in the ward and in your clinic, the less likely you are to lose it.
Definitely very inciting, in fact, especially in the present scenario where many of the newer generation of radiation oncologists who feel that contouring is one of the major part of the radiation therapy. This is going to affect, and is also in the era when medical oncologists are taking over everywhere immunotherapy, and so ultimately, if we are not clinically improving ourselves, we are going to face the challenge.
Thank you, sir, for an innovative session. Next, moving ahead, we have a last session of two-day conference, and it's on IO for advanced or relapsed head and neck cancer by our very own Dr. M. Vamshi Krishna, Director, HOD, Medical Oncology, AIG Hospitals, Hyderabad.
Good afternoon, everyone. For the medical oncologists in the hall, IBM Watson failed, so our jobs are safe for a while. So, right. So I'm standing between you and lunch, and I will not take too much time. It has become de rigueur that every meeting of oncology has to have some session on immunotherapy. So I will do that part, and I'll talk of immunotherapy in head and neck cancers. Now, remember, when you talk of metastatic refractory relapsed head and neck cancer, what you're basically looking at is two subsets of patients. One who are already platinum exposed. When we say platinum, it could simply mean the patients who are taking treatment with cisplatin during CTRT or who have received chemotherapy for any reason. Now, in that group, you have somebody who has received platinum less than 3 months earlier or less than 6 months. Now, why this dichotomy? Because different trials have used different headings. That group is probably what we call the platinum refractory. The second group is which is platinum sensitive. Was a trial ever conducted to say that this is refractory, this is sensitive? Not really. This has been what the trials have used as a cutoff. It's more of a, I would say, practice rather than an absolute. So keep that in mind. The rest, of course, is the platinum naive, which includes all the upfront metastatic disease. So now, having gotten this out of the way, what is our baseline? The baseline started with this extreme protocol, which was pretty extremely in the past. A lot of people who have passed out this would have been much before that time. Now, importantly, this trial of cetuximab platinum 5FU was done only in patients who had a platinum sensitive disease, more than 6 months, as I've highlighted. And then, of course, it was very clear you give Cetux plus carbo or cis plus 5FU versus only chemo. This set the bar. Hazard ratio of 0.8. Now, today, with all the immunostudies, with all the studies, 0.8 is considered just about acceptable. It was significant, but just about acceptable. More importantly, look at the number it established, 10.1 months. So that's the bar you have to beat if you want to be better than extreme. 10 months overall survival versus 7.4 for other treatments. So then came in 2021, the first line trial of Keynote 048. The phase 3 study of first line pembrolizumab, and it was basically a trial with 3 arms. You had pembrolizumab monotherapy, pembrolizumab with chemotherapy, and then cetuximab with chemotherapy. So remember, extreme versus pembro with similar chemo and pembro monotherapy with stratification, and one of the most complicated, annoying and irritating studies to analyze because of this. Look at the endpoints. Their endpoints of CPS, which is what we use for PDL1 marking, more than 20, more than 1, total population, OS, PFS for Pembro versus chemotherapy, arm A versus arm C, and then B versus C. This trial had 13 endpoints. Okay, so remember, this is not an easy trial, does not give you a single conclusion. That is why I'm highlighting this point. Because like all doctors, we want simple answers. We don't want complicated answers, but unfortunately this trial is complicated. So when you looked at the results, now the Pembro versus the chemo in that high CPS 20 arm, there the monotherapy arm showed a overall survival of 10.9 months, 14.9 months. So your bar, remember, extreme was 10.1. Here it was 10.7, similar, 14.9. So big jump. So this, I think, is something we all be happy about. Keen observers will note the trials cross, the curves cross. So your chemo, the immuno arm actually starts doing better as you go forward. Initially, there's a crossing over of the curves. Then what about the CPS more than 1? Remember that they try to look at both. The number dips. You get down to 12.5 months. The typical argument against oncologists saying it's only a couple of months that you're going to increase. Fair point. But again, the curves separate and they remain separated. And in immunotherapy, we want that separation. If you don't find that separation, you're not happy. You find that small separation later on. So far, so good. What about the overall survival? This is the PFS. And there things become interesting. Look at the PFS. Absolutely hardly any difference. In fact, your Pembro does worse. You have only 3.5 months of Pembro monotherapy versus 5 months with the chemotherapy. Look at the CPS 1. It's only 3.5 months. Effectively, for a lot of us, we do the first scan after 3 months, and that's when you're going to see progression in quite a few patients. So this is a caution. Remember, just because you have a high CPS, your monotherapy doesn't do fantastically well. Okay? The PFS wise, they don't do well. Interestingly, statistically, you still are getting a hazard ratio of 0.99. It is still on one side, but it is not significant. Right. What about the chemo plus Pembro? What about that? Look at the overall survival, overall population. Hazard ratio is fine, but 13 versus 10.7 months. So here you're seeing the benefit. PFS, again, no benefit. 4.9 versus 5.1. So you're better, but your Pembro doesn't seem to add anything to the PFS. Adding to the overall survival, not to the progression-free survival. So, if you have to start off looking at the overall efficacy results, when you start looking at this breakup, chemo versus chemo and Pembro monotherapy, this is what you're getting. In Pembro plus platinum plus chemotherapy, your overall survival is 12.7 months. In monotherapy, it's only 10.8 overall. PFS, frankly, is same everywhere except for the Pembro mono, which is quite low. So, in a nutshell, if you have a CPS more than 20, both Pembro and Pembro chemo do well. Obviously, the Pembro will have less toxicity. However, in both these cases, your PFS is not different. It's similar, or in fact, even some cases inferior, like I showed you. What about CPS 1 to 20? Pembro versus chemo, it is non-inferior, better tolerated, almost same PFS, almost same overall survival. Pembro chemo is better, it is also equally well tolerated. So that's where you are. CPS less than 1, Pembro chemo is better than chemo and cetuximab. Why is this important? Because everyone from every surgeon nowadays has, first thing they ask is, we are sending CPS, because they have learned that PDL CPS means something. What does it mean? This is what it means. It doesn't really matter so much. If you have higher CPS, then yes, you're getting better results. Now, for various reasons, NCCN and everyone have accepted these very, very broad guidelines and say that Pembro Platinum 5FU is a category 1 and Pembro monotherapy is a category 1 for CPS more than 1. Remember, 1 to 20, you do not have a PFS advantage. So if I get a CPS 5, I should be prepared that my PFS may not change. I'm only looking at a OS advantage, which will happen later. Okay? That we should be careful about. It's not a panacea. So this is what the NCCN gives. Again, I'm not very sure whether this is the best way to give it. The devil lies always in the details. Now, this detail is not there in the main paper for anyone who reads. If you can manage to go through the 13 endpoints and the paper, which is difficult in itself, look at the supplement. And what you see is in the pembro monotherapy arm, your progressive disease is close to 27% in CPS more than 20, which means 1 in 4 patient is going to progress within the first 3 months. When you look at 1 to 20, just CPS more than 1, it jumps to 39%. In the total population, it is 41%. So anyone who just says, oh, give IO, it's great because you have a high CPS, be prepared for this. You can have progression, and all of us have burnt our fingers by using this because progressions are there. What about pembro plus chemo? It's acceptable. You have 17%, 18%. So that is somewhere acceptable. We know with any chemo, not everybody responds. 17% is acceptable for me. 40%, I have to be very careful, especially because our traditional counseling for immunotherapy has been great drug, no toxicity, you will do well. Sorry, that's not the case. Let's be careful about it. And which is why I said the whole NCCN recommendations are something that I really will not agree in its entirety. Right. What about low dose immunotherapy? Whenever we talk of immunotherapy, low dose cannot be changed. One of the authors is there with us here now. And this paper really was like something we were all waiting for in India, and it was an Atmanirbhar product. So we were all very happy about it. The trial was very simple. You looked at recurrent HNSCC with a palliative intent, including patients who were refractory. You did not differentiate and say more than 6 months. Pembrolizumab said only more than 6 months cisplatin should have been there. We did not specify in this trial. The comparator arm was cisplatin, not cisplatin 5-FU, not a doublet, not immunotherapy, not cetuximab. It was plain cisplatin. The arm B used a oral metronomic therapy. This was the first study. And then along with that, low dose immunotherapy of around 20 milligram was added. Now remember, immunotherapy nivolumab dose is actually close to 140 to 200 mg. So you're using 10% of it. There are very scientific rationale why they did. I'm not saying it was wrong because there is a rationale. We don't know the actual dose of immuno needed. But this is what was done. And the aim of the study actually is affordability, which the authors have very correctly said that, look, nivolumab full dose is inaccessible. And this trial will have a good implication in terms of cost of therapy, and we can use it for a lot more patients. And this is what the implication of the editorial comment also said, that where you are having survival, if you are able to give the full dose keynote 048, your actual survival is much higher than this trial. And this is in fact what Dr. Vijay Patil himself said, that look, addition of low dose immuno to metronomic is improving the overall survival. It's an alternative standard of care. It is not the standard of care for someone who can afford a full dose immunotherapy. So again, words of caution. So let's go with these trials. You have the extreme, you have the keynote 048, and you have this low dose immunotherapy trial. 440 patients, 880 patients, 151 patients. What did you compare it with? You compared it with chemo in one side, chemo plus cetuximab, and only oral metronomic therapy. So your comparator arm is different. Now, interestingly, despite that, when you look at the PFS, the extreme had only a 3.5 month PFS. The triple metronomic actually has 4.5 month survival. So if you ask me, metronomic versus chemo, I think both work well. They're good enough. Whereas in the keynote trial, again, the PFS is around 4 to 5 months, which is what you would expect. Overall survival, 10 versus 7.4 I showed you. Pembro, everywhere it's 13 to 14 if you are able to give Pembro plus chemo. The low dose immuno gives you an overall survival of 10 months. It's good. It's almost as good as extreme, but not better than the full dose immuno with chemotherapy. Again, not to say that I don't like the low dose. I use it very frequently, but remember, it is not compared to the full dose immuno with chemotherapy. One reason could be the high number of platinum refractory patients in it, and potentially the number of PD-L1s were maybe slightly different, which we don't really know. So then, what will we conclude with this? I'll come to that in the ending. Are all immunotherapy drugs working equally well? Is everything successful? And the answer is again no. You had the nivolumab, ipilimumab versus extreme regimen. In first line, checkmate 651. No difference. The overall survival in both the groups was same, whether you used a PD-L1 high or low. So this drug doesn't work. You have the Eagle study, which was a durvalumab in refractory setting. No difference. Again, the numbers are similar, 10 months, 11 months, but no overall survival advantage. You had the Kestrel study, which again looked at durvalumab with tremelimumab in compared to the extreme in first line platinum sensitive disease. No difference. So, like the famous song goes, the birds fell off the high shelter, the eagle studies and the Kestrel have all failed. So, the birds are falling. So, that tells you that not all immunotherapies work. If you want to use something, use what the original keynote study used, and then you'll probably get your results. What about the platinum refractory group? This is the platinum refractory 2 trials, the phase 3 checkmate 141, that was nivolumab, which looked at again comparing to single agent chemotherapies. We had a very interesting case discussion yesterday where there was a patient who had actually platinum refractory, but still immuno was given. Remember, as per approvals, it's usually given as a single agent, not with chemo or with something else. So nivolumab here showed a benefit in terms of your overall survival of around a couple of months. 7.5 to 6.1 showed some benefit. Keynote 040, again in platinum refractory, where it compared to single agent chemo, gave you a benefit of 0.81 hazard ratio, OS of 8 versus 7 months. Now these are a bit depressing numbers. You're talking only month advantage. Again, we still give it. We are not saying it should not be given, because some of them, when you see the end, the tail, there are patients who do for longer. So that's the available evidence. Now I showed you the NCCN, which gave a blanket approval for pembro monotherapy in CPS above 1. ESMO is slightly better. Now these are the Pan-Asian guidelines of ESMO, which are published every 1 to 2 years in head and neck. A couple of doctors from India were involved in this. They said, again, if it is more than 20, you can use pembrolizumab monotherapy. More than 1, both options are given. And similarly, the Indian consensus guidelines were made by Dr. Kumar Prabhasharan et al. And they again gave a similar thing. Cetuximab still remains one of the options. Monotherapy is recommended only more than 20. So the Indian guideline is actually a little bit more sensible in my opinion, because they're giving a more rational way of treating as per the trial. So how do I treat? I mean, whenever you look at this point, there are always 2 ways of treating. You can stick to guidelines. You say, okay, I follow NCCN. NCCN gives, I give it, no problem. You can stick to the FDA approval and say, oh, FDA has approved it, so I'm going to use it irrespective of any country thing. Middle path is a bit of a common sense, which does not tell you to just look at the trial. It tells you to look at the patient. Look at the biology of the disease. Look at the disease burden. Look at your expectations. You're asking someone to spend more money with the hope of a couple of months median survival. Now, median means 10 to 15% can do longer than 1 to 2 years as well. So you have to put it in context and tell the patients, look, set your expectations. If 100 patients are like you are treated, 15, 20 will do very well. 50 will do this much. And that's what you're spending the money for. And that's how you set the expectations. Ensure they have the support system to follow. All of us as medical oncologists have patients who have done very well. I have a patient who is now 3.5 years on immunotherapy, pembrolizumab, and doing perfectly fine. So I cannot look at that one patient and then ignore all the other patients who progress within 6 months. And that's how we have to set the expectations. Finally, a theme again, we were talking of it in laryngectomy. Let the patient decide after discussion. And this is equally important here. Have a decision after discussing with the patient. So immunotherapy is a great revolution. It has really changed how some patients respond. We all are aware of that. But again, remember, it does not work in every case, and it works where it works very well. Patient selection, patient discussion is extremely important. So thank you.
Any questions? Thank you very much, Dr. Vamshi. You had all our attention despite being the last batsman. So before we close this meeting, there are a few people that we need to thank. Our esteemed faculty who come from all over the country as well as different parts of the city. Thank you for taking your time. Our academics team, we owe all of these meetings to them. They are the heart and soul of all of these meetings, headed by Mr. Satyanarayana. I just heard that they were here in the hospital till 3 a.m. last night, and they're still here in a few hours. Our audio-visual team headed by Mr. Mohan, our marketing team headed by Mr. Sahu for taking care of all of the logistics seamlessly, our F&B for the sumptuous food, a whole lot of volunteers who agreed to come here on a Sunday, and you delegates for making the conference a huge success. I hope this was beneficial for you. And we hope to see you soon in January for the AIG Cancer Summit. Thank you very much once again, and we can proceed for lunch.